Good evening and a warm welcome to all the faculties and delegates. First of all, I would like to thank each one of you for registering and joining us today for the Oncology Review 2022, a review of key scientific learnings in oncology from the year 2022. I would like to thank our academic partners, BD, Glenmark Oncology, Viatris, AstraZeneca, Janssen Oncology, and Intas for supporting us in the virtual meeting. I would like to invite our program chair, Dr. Suman Gupta, a renowned cancer expert and has a vast experience of treating all sorts of cancer. He has been accredited by many awards for Best DM Oncology Fellow. He is Senior Consultant and Head in Department of Medical Oncology, Hematology, BMT. He is also Director in Metro Cancer Institute, Faridabad. And I would like to invite Sir to give us a welcome address. Thank you and over to you, Sir.
Thank you, Priyanshi. It was too much of a humbling welcome in our own seminar. So I am really thankful for everyone for joining in, all the faculty, delegates, and especially thankful for the back-end team from Mice Ideas. I think we'll be trying to figure out everything on time because we are near the Christmas holidays. So I will like to hand over the stage back to the organizers so that we start with the first session. Thank you, ma'am.
Thank you so much, Dr. Suman, for welcoming all the faculties delightfully. Now, let us begin with our first session, which is on supportive care. And this session is supported by BD. And I would like to invite Dr. Priya Tiwari. She's Senior Consultant in Department of Medical Oncologist and Hematologist, Artemis Hospital, Gurugram. And she's going to speak on PICing up the right VAD, perceiving the veins. Thank you and over to you, ma'am.
Hello everybody. I'll just start sharing my screen.
Yes, ma'am, you can share your screen.
Yes. So a very important discussion for vascular access, picking up the right VAD, vascular access device. So just to bring the background for the today's meeting, venous access is critical for every cancer patient, and oftentimes we actually don't discuss this topic enough. But yes, we understand that for the cancer patient, especially for the advanced cancer patient, this is very important. We have chemo ports and PICC lines which have a place in the medication delivery system, and irrespective of individual preferences, some patients are best suited for one and not the other one. So what are the objectives for today's meeting? Is the understanding global guidelines related to PICC lines and understanding the Indian practices and what are the barriers and how can we resolve them. So patients usually have many options to what we can offer. So you have medlines, we have prolonged well PIVCs, long PIVCs, short PIVCs, central ICCs, peripheral ICCs, tunneled CVCs, and yes, of course, chemoports. Now, what is an ideal vascular access device? Which is easy to insert. We say chemotherapy, PICC line, one of the advantages over the chemo port is that we say, oh, you're going to start chemotherapy, we'll put a PICC line and we'll start. For chemo port, you have to send the patient to the surgeons, get sometimes, especially sometimes PAC checkups, etc. So yes, easy to insert is one of the very important pointers. They should meet complete venous access needs. So if you want to use them for TPN, for chemotherapies, for fluids, for blood, for phlebotomies, you should, fill all the purposes. You should avoid complications. The least possible complications should be there. Central lines, we have also suffered that it can cause sometimes pneumothorax. Yes, and promptly remove if not needed. And yes, they should have minimal or negative financial impact. There are certain therapeutic goals for every line to determine the priorities. For central access, they are predominant. What are the goals that time is for the central access, like monitoring of the CVPs. And yes, you can use for phlebotomies. You can use for the vasoactive medications, for the vesicants, of course, TPN, complex fluids, etc. Peripheral access, more for the volume resuscitation, blood product administrations, medications, etc. So yes, venous access, it can dramatically affect a patient's ability to receive appropriate treatment. And that is what I'm saying. It's very important that we should have a discussion regarding this. We have had so many patients where, that at the time of giving chemotherapies, the IV access is not found, multiple pricks are there, and that can actually lead to default rates also. And sometimes patients say, I can't take an IV chemotherapy because it requires multiple pricks, so please put me on oral tablet. It's such a common statement. So yes, it's very important discussion that needs to happen, and it has to be a dynamic discussion. Sometimes your patients have upfront very good veins and you're giving chemotherapies using venflons, but over the period of time they get exhausted. So this discussion also has to be a very dynamic one. That, and initially sometimes patients are not willing for these PIC line, but again they will understand after some time that yes, it's very important for their treatment. So it has to be a very dynamic discussion and not just a one-time discussion. So do we need an Indian algorithm, and how to use PIC lines in our cancer patient? It's very important because there are gaps at various levels. There is gap at the level of awareness. There is gap at the level of training. There is gap at the level of system. At many places we don't have a system of putting PIC lines. Okay. Also, there could be a lot of casual approach leading to complications. We need to have a dedicated venous access teams so that it can take care of not just putting the lines, but also ensuring that the line is cared well with proper aseptic precaution. And yes, we also have several unique Indian experiences which have led to unique solutions. So what are the global guidelines? So just to discuss some data is that lack of venous access actually affects your care, and it affects the continuity of chemotherapy for our patients. 70% of the patient will receive irritant vesicant chemotherapy and will experience phlebitis. 70% of the patient receiving irritant vesicant chemotherapy will experience phlebitis, and 20% patient receiving irritant vesicant chemotherapy experience extravasation. And we all understand extravasation is so difficult to manage. Sometimes it can also delay your next chemotherapy cycles, and of course leaves a very bad experience in the mind of patients. So there are a lot of factors which will decide that what is the kind of line that one needs to put in, but one of the important factor is the duration for which you are trying to use a venous access. So suppose if it is very small, like up to 3 to 5 days, then a peripheral IV cannula or ultrasound guided peripheral IV cannula suffices. In ICUs, most commonly for critically ill patient, the way to go forward is usually the central venous catheters or the midline catheters. But yes, for our cancer patient, we tend to prefer the PIC lines, the tunnel catheter, or the ports. Uh, so this has to be seen again that yes, the duration of how long is the duration of therapies, because yes, that is what we need to explain to our patients also. Now, if you require some kind of vesicant irritant infusions or the duration of therapies is small, then the port is not the good idea. So suppose if it is less than 30 days, then the chemo port is not the best of the choices. We tend to keep chemo port only if more than 30 days of treatment duration is actually required. But yes, the PIC line can serve a purpose because it's easy to put in, and we all find it very convenient to use. So it can be used for the small infusion as long as small duration of treatment, as well as for a long duration of treatment. Also, port are not supposed to be used for the frequent phlebotomies. You put in a needle, take out a sample, it becomes very cumbersome also. But PIC line is something where you can actually use for the phlebotomy purpose also. Tunnel catheter can also be used if you are having a duration of treatment for more than 15 days. So just to summarize, PIC line is recommended. You can use it for vesicant, for irritants, and yes, for the day 1 to long-term therapy, PIC line recommended for patient requiring frequent phlebotomies, independent of type of infusates. And for long-term usage, all three are possible: PIC line, tunnel catheter, or port. The selection are based on the patient factors. So what are the factors we should take in account by creating an Indian algorithms? So it's very important that what is the treatment patient is receiving, type of infusates, the kind of chemotherapy patient is taking, the duration of chemotherapy, not just the duration of therapy, but duration of chemotherapy, whether it is a 2 hours infusion or a 24 hours infusion or 48 hours infusion, like you have regimen of FOLFIRINOX, etc. Expected duration of therapies, indwelling time of the VADs, vascular integrity of the patients, patient appropriateness, intensity of dose, and yes, the cost factors. So if based on the expected infusates in the treatment journey, that deciding upon the choices, we need to see what is the duration. The short infusion or number of cycles is less. Because like I previously said, that the chemo port is something we tend to prefer if the duration of therapy and especially the number of cycles is more, and we feel that the treatment is going to be long. Whether we are requiring, patients are requiring infusions, longer infusions, IV maintenance, 12 months or more. And if the patients are also taking multiple other simultaneous treatment like chemotherapy in addition to monoclonal antibodies, immunotherapies. Vesicants and irritant drugs are there, chemotherapy are notorious for this, and that is one of the reasons that we tend to prefer a good IV access, and that is why we always tend to check the back flow as well as the forward flow while administration. Because yes, managing the side effects of extravasation are also very difficult and challenging. So this is the slide to show what are the vesicant drugs, the anthracyclines, Wilca alkaloids, alkylating agents, and what are the irritant drugs such as the etoposide, teniposides, Texanes are also irritants, platinums are irritants, mitozentron is also irritants. So consider a proper kind of venous access device for all vesicants irritating drug to avoid any vascular complication. Preventing extravasation and thrombophlebitis by these measures is very important, and that also helps in avoiding frequent breaks for the phlebotomies and repeated infusions, including blood products. So what is important is we need to take into account, this is a very common question. Patients will ask you, if I'm being inserted a PICC line, how long can I keep it? So the guidelines also say that PICC line is intended for patients requiring up to 12 months of IV therapy, and the use of PICC line is approved for up to 12 months. So you can keep a PICC line for up to 12 months. It's also very important for pediatric malignancies. You can use PICC line for the pediatric cancers also, and there are a lot of chemotherapy protocols in pediatric protocols which are actually very long. A PICC line can be cited for the treatment lasting for a few days to many years, and you can actually, there are studies which say that you can actually keep it for up to 34 months, and that is why the PICC line handling is very important, isn't it? So PICC lines are typically utilized for those therapies that have a duration of 2 weeks or more and have a demonstrated mean dwell time of 10 to 73 days. However, the more than 300 days are also frequently used, and PICC line is used for this purpose. So just coming to some more evidence, this was a study for 269 PICC line, 250 patients, 98% of the solid tumor patients, 55,293 of overall catheter days with median 184 days. So the study suggests that the PICC lines can be successfully utilized as a safe and long-lasting venous access device in non-hospitalized cancer patients. So you see a range of 15 to 1384 days. So really long range, and yes, we all understand that yes, PICC line can be kept for a really long duration. So that is 3.8 years. So in India, several centers have used PICC line for 12 to 18 months, and even our experience is something of those sort. So do we ever estimate what is the patient will go through during the expected journey? We are so much focused on the chemotherapy and its side effect. We just don't take into account the number of pricks patient will have during the blood sampling, during the chemotherapy administration, and administration of supportive care, blood products, IV fluids, and all those things. Also, number of lines of therapy. For various cancers, we now have multiple lines of therapy thanks to the progress made by the science. But the problem is that will again involve, yes, the good IV access. For lung cancer, for ovarian cancer, especially for breast cancers, we have multiple lines of therapies, including infusional chemotherapies. And yes, that will entail using these vesicants, irritants at some point of time. So yes, both PICC line and the port can be used for a long time duration. So this is just a slide to show that an NSCLC patient with no driver mutation, no overexpression of PDL1, 3 lines of chemotherapy. Pemetrexed, cisplatinum, Texanes, we have minor albins here, and so on and so forth. So you, if to calculate the number of pricks for the blood test as well as for the this administration of treatment, 72 pricks approximately, assuming only one episode of febrile neutropenia, and average blood sampling during treatment 25 needle pricks. So yes, this is very important for the patient. This is also the part of journey, and the quality of life is also impacted by this. Again, 58-year-old carcinoma ovary patient with obesity and venous status compromise. So again, we see that there was an extravasation after chemotherapy. So hand change extravasation in second hand after 4 cycles. So you go on, here the PICC line was inserted. So you understand when the extravasation happens, we have had patients who have required plastic surgery because of the extravasation and difficult to closure and the wound to heal. And yes, that also compromises the treatment intensity later on. So it's very important that you take care of the venous access properly. So venous status to be checked for every patient before starting chemotherapy and before each cycle or infusion. So understanding barriers. So this was a very important study by Kovin Babu and the team to understand the outcomes, cost comparison, and the patient satisfaction. For the median catheter indwelling period, for PICC line it was 59 days, for chemoport it was 137 days. And yes, the cost of the chemoport was significantly higher, so compared to the PICC line. Also, compared to the central lines have a lot of side effects. PICC line comparatively has less side effect, and that was also reflected in this particular study. So you don't see any hematoma, any shoulder pain, etc. Also, difficulty in insertion is not seen with PICC line. So it's very easy to use, and even our experience is that easy to insert, especially if you are using an ultrasound guidance. So the challenges, to summarize, is at the level of system. Many of the places you just don't have a system to put in these kind of lines or the peripheral access devices. Patient might have fear about side effects. They Google, they find out, oh, this can cause infection, this can cause bleeding, this can cause thrombotic formation. So there's just a lot of fear. So you need to alleviate that fear, that yes, every side effect and every problem can be actually addressed in a meaningful manner. The nursing care has to be improved and properly dealt with, because it's very important that you should have an aseptic handling. And sometimes when they are doing the dressing, it should not just come out. The compliance for the flushing, PICC lines requires once a week flushing compliance. So one needs to be ensuring that. And yes, cost is also one of the challenges. Well, now this is a very important study. If a nurse-led PICC line insertion, is it cost effective? So yes, the study concluded that if we teach our nurses, it is much more cost effective than the radiologist putting in a PICC line. So the availability of radiologists is a problem all the time, and also the nurses you have more nurses, and if they learn, it will be much more cost effective. So the study concluded the radiologist group has a statistically significant increased cost over the nurse group. So majority of the PICC line can be safely performed without an X-ray screening in a ward-based environment. This is likely to be the most cost-effective solution for a large volume services if we teach our nurses to put in PICC line. So if your institution policy permits it, trained nurses can insert PICC line, which reduces the cost by 60%. Insertion rate is better, 91.6%, and the complication rates are also low. So the similar ideologies have been put forward by the various other agencies. Also, if you're doing an ultrasound guided cannulation or any central vein for long-term central venous access, so it is always preferred for the placement of long-term vascular access device. It has been shown to significantly reduce early mechanical complications. So ultrasound guided insertion is always preferred, and that has been across, even the usual practice has become that if you have this facility, then that should be used. So ultrasound guided insertion reduces all complications, mechanical infections, thrombosis, making it very cost effective. So the important points to discuss, the thoughts, is how is the patient compliance in terms of weekly dressing and flushing. Sometimes this might be very low. Patients are sometimes it's they are looking at alternative. If somebody can do a dressing by by paying a home visit, and actually this can also be a part of the care to be decided, that if the dressing can be done at home. And flushing, what percentage of your patient require premature removal of PICC line due to complications, and what measures can be taken to improve compliance or reduce complications. So how can we further increase better the care of the PICC line? So care of the PICC line needs adherence to all aspects of checklist. There's just no shortcuts. Suture-less stabilization device, that is stat lock, and pre-filled saline flush. So this is what is a stat lock is, which is stabilization device, which has demonstrated many significant advantages for both patients and healthcare providers compared to the conventional methods of catheter securement. It eliminates need for sutures, accidental needle sticks, reduces unscheduled restarts, reduces catheter complications, and yes, increases catheter dwell times overall. And that is what we want. Pre-filled saline flush is also very important. It improves patient outcomes. So designed to eliminate the syringe-induced blood reflux, assures sterility with terminal sterilization or maximum sterility assurance level. It reduces the risk of medication errors with a clear labeling, reduces the risk of catheter damage, and reduces waste and cost. So just to summarize, these kind of vascular devices are recommended for all vesicants and or irritant infusions. Also the chemotherapy infusates. Also the chemotherapy agents having a pH less than 5 or more than 9. Infusates with osmolarity of more than 600. TPN, blood and blood products. Need to make habits of formally checking and documenting venous status for every patient who will be starting chemotherapy. Every center must provide option of chemo port and PICC line. Contrary to common misconception, PICC line has been successfully used for short, intermediate, as well as long-term therapy, more than 1 year. Benefits in both continuous and the intermittent chemotherapy. Now, what is important is that there are various companies which are now helping for the training of the nurses as well as the rest of the staff, so that they become aware of what are the precautions to be taken while inserting PICC line, how the care has to be done, and yes, that helps to overall improve the cost effectiveness of these PICC lines. So yes, the companies are coming forward for the training purpose, and that is what is very commendable. Thank you.
Thank you so much, Dr. Priya, for such an informative talk. Now, let us move on to our next session. And for that, I would like to invite our chairperson. Uh,
Hello.
Uh, our chairperson, Dr. J.K. Singh, a Padma Shri awardee, past president, Indian Society of Oncology. He's also chairman in Sri Sai Institute of Medical Sciences, director in SS Hospital and Research Center, Patna. Over to you, sir.
Thank you, Priyasi, for the nice introduction. I'm sorry that I could not join earlier because I was stuck up in a road jam. Anyway, my second topic of this session is chemotherapy
Sir, it
induced.
is, sir, it is written over here.
Okay, okay. That's a new age in chemotherapy induced nausea vomiting management. Okay. So chemotherapy indicated nausea and vomiting remains one of the most challenging problems of chemotherapy affecting the patient and posing a great problem to clinicians also sometimes. We need to have a optimum CINV control every time when we are using chemotherapy. In the present era, although we have varieties of drugs like SST3 receptor antagonist and the NK1 receptor antagonist, which is found to be very much effective in such cases and controlling immediate and delayed control of CINV. But in spite of these drugs, we still find difficulty in some of the cases to control CINV. I'm sure the learned speaker will try to discuss about the details of the new drugs, which has come recently and enlightened about its mode of action. So I will request the speaker, Dr. Advita Egore, Associate Director, Department of Medical Oncology, Nanavati Max Super Specialty Hospital, Mumbai, to start his presentation, please. Dr. Advita.
Thank you, sir. Um, as sir had rightly put it, we chemo-induced nausea vomiting is something which is very, very underreported by patients, and it is something which
Okay.
we all need to assess very, very clearly in terms of deciding the chemotherapy protocol, so as our patients do not have untoward experiences. Now, in this presentation, what I'm going to speak about is to give an overview of the CINV, some guideline recommendations, to tell you about the new preparation IV Akinjo, which is a combination of netopitant plus palonosetron intravenous, certain advantages that I would highlight, what is the clinical evidence, and conclusions. So, as Dr. Singh put it, CINV does adversely impact the patient's quality of life, and this has very well been studied way back in 92 in this paper, which says that patients who are experiencing CINV, the mean quality of life index scores are much lower post chemotherapy as compared to patients who are not experiencing CINV. And there is also a marked difference in terms of what physicians and even nurses perceive as compared to the reality. And there is a gross underestimation of the emetic risk. This is more so magnified in the situation of delayed nausea and delayed vomiting. As we see, this is a study which was published by Professor Grunberg in 2004, which compared the doctor or the registered nurse's prediction versus the patient experience. And in terms of acute nausea vomiting in the highly emetogenic chemotherapy, we are quite well matched with what the patient experiences. But in terms of delayed nausea vomiting, even the doctors tend to underestimate the risk of delayed nausea vomiting. The efficacy for controlling the CINV has actually progressed a lot over the last 3 years. We see that with the cisplatin and AC, the intramycin cyclophosphamide classical chemotherapy regimens, which have been in use since 1990s. Then initially, the 5-day complete control rate was only about 10%, increased to 50%, and now we are somewhere about 75 to 85% with the addition of newer drugs in terms of the 5-HT3 inhibitors, the NK1 receptor antagonists. So NK1 receptor antagonist in the prevention of delayed CINV has been a drug which has really changed the way that we manage highly emitogenic chemotherapy and even some moderately emitogenic chemotherapy. The NK1 receptor antagonists are generally used in combination with the 5-HT3 receptor antagonist, which results in a better control for acute as well as delayed CINV. We see these three curves. The topmost curve is for the 5-HT3 plus dexamethasone plus the NK1, where even in terms of the delayed nausea vomiting, that is up to 60 hours, we are seeing that there are almost about 70% patients who are free of emesis. If you look at only the 5-HT3 and dexamethasone, and this is in cisplatin, which is an HEC group, only about 40% of patients are free of emesis in terms of the delayed nausea. And only with the NK1 receptor and the dexamethasone, it actually doesn't work as well as the combination. So looking at certain anti-emesis guidelines, we've seen that the guidelines which are evidence-based, this efficacy is on basis of 13 randomized trials involving more than 7,500 patients. When we look at the drug cisplatin, about 2,700 patients treated across 5 large randomized trials. Absolute benefit with the addition of an NK1 receptor antagonist is about 16%. In terms of carboplatin, almost 1,100 patients, 5 randomized trials, 14% absolute benefit with the addition of NK1 receptor. And in an AC regimen, 3,600 patients, about 12% absolute benefit with the addition of NK1 receptor antagonist. The guidelines differ minimally for the NK1 inclusion. So in terms of the ASCO, MASCC or the ESMO and the NCCN, HEC, which includes cisplatin, AC and carboplatin AUC more than 4, all of them recommend an NK1 receptor antagonist for acute nausea vomiting. In terms of MEC, this is a recommended option by the NCCN. For MEC patients, those who are having additional risk factors for high risk of nausea vomiting, or they have failed a previous treatment using a steroid and a 5-HT3 receptor antagonist as dual agents. So what is new in IV NEPA? This is a next generation NK1 receptor antagonist, a water-soluble phosphorylated prodrug, netopitant 235 milligrams. This is the bioequivalent dose of the oral NEPA, which is 300 milligram. And this does produce high, more than 90% receptor occupancy and lasts for more than 140 hours in the brain after single oral dose. The combination partner is palinocetrol, which we know has a higher binding affinity and a longer half-life of almost 40 hours as compared to the other 5-HT3 antagonists. This is selective for the 5-HT3, and there is an allosteric binding and positive cooperativity, which is seen between the NK1 as well as the 5-HT3, and this results in long-lasting inhibition of 5-HT3 receptor function. Now, this essentially was to offer an additional convenience for doctors and patients to use a fixed IV formulation of NEPA plus palinocetrol. And this is the first netopitant is rapidly converted to netopitant in vivo following IV administration. And this is equivalent to the oral formulation. And this corresponds to 260 milligrams of phos-netopitant chloride and equivalent in the AUC exposure to oral netopitant 300 milligrams. So looking at the safety evaluation, this is a first phase 3 study in chemo-naive patients with solid tumors. These all patients received IV NEPA plus dexamethasone over initial and repeat cycles. These patients had to receive at least 4 consecutive cycles of AC-based chemotherapy. And the design was a phase 3 randomized double-blind, double-dummy parallel group multiple cycle study, and oral NEPA served as the control. Females with more than 18 years with breast cancer, including recurrent metastatic disease, with a performance status of 0 to 1, and they were naive to any MEC or HEC chemo regimens. This study was conducted at 56 centers across 11 countries between November 15 and August 17. Randomization of 404 patients was done 1:1 for cycle 1 with IV NEPA, dexamethasone 12 milligram and dexamethasone 8 milligrams day 2 to day 4. and it was compared to oral NEPA plus the same dose of the steroid. And the IV NEPA was administered as a 30-minute infusion 30 minutes before starting chemo. The oral NEPA was given as a single capsule 60 minutes before the chemotherapy. So when we look at results in terms of adverse events in all cycles, the adverse event profile for the entire study period was similar in both the treatment groups. There was no increase in the incidence rate or total individual adverse events across any cycles, whether it was treatment related or not related to the therapy. In terms of local tolerability, and this local tolerability was essentially evaluated because IV phosphorepipridine does have a lot of irritation and thrombophlebitis as one of the complications. And these were patients who even took. Hello. Hello.
Hello.
Yeah. Hello. So these were patients who even took chemotherapy through a peripheral IV line. Not all were treated through a port or a PICC line, and injection site reactions were practically not seen. In terms of QTC prolongation, which is another concern for all of us, there were the main in cycle 1, the mean changes from baseline QTC were small, and they were similar between the groups. There wasn't any QT prolongation which was seen. Now, when we look at the IV NEPA pooled efficacy data in the AC regimen, in these group of patients, the patient baseline characters, mean age was 55 years. Most patients were Caucasians, and patients, almost 75% patients were ECOG performance status 0. In terms of extent of cancer, about 40% were localized and 47% had locally advanced disease. 57% and 43% patients received EC or AC. When we look at treatment-related adverse events, there were no serious treatment-related adverse events associated with IV NEPA. Only one serious treatment-related AE was noted in the oral NEPA group, which was atrial fibrillation in a patient with a history of valve prolapse. No patient died on the study, and no treatment-related adverse events led to study discontinuation in either treatment group. Similar incidences of treatment emergent adverse events were seen for both IV as well as oral NEPA groups, and the most frequently reported were consistent for those expected for patients undergoing AC-based chemotherapy, namely the alopecia and leukopenia. No infusion site hypersensitivity or anaphylaxis like treatment emergent adverse events were reported. The infusion site events were rare and they were deemed unrelated to the IV NEPA. Only about 1.5% patients receiving the IV NEPA experienced any infusion site adverse event during any cycle, versus 9 patients, that is 4.4% in the oral NEPA group. In terms of complete remission with no MSS, no rescue medication, and no nausea rates, they were similar between treatment groups and well maintained over cycle 1 to 4. We see here 86.5 versus 88% during the acute phase, and 75.5 versus 78% during the delayed phase. The results in terms of quality of life, the dark green is the IV NEPA, light green is the oral NEPA plus dexamethasone, and they remain very well matched. This is the second study of Japanese data in HEC setting. These are patients who are on highly emetogenic chemo, and there was a randomized double-blind phase 3 study of using IV Akynzeo versus phosphorepipridine for prevention. This is the console study. This study was conducted at 82 sites in Japan, February 19 to March 2020. It was in 2 parts, the S cycle or the first cycle, and then multiple chemo cycles labeled as M. So first cycle and then cycle 2 to cycle 4. The S cycle evaluated non-inferiority of phosphorepipridine versus phosphorepipridine, which was administered IV with palonosetron and dexamethasone. And the M cycles evaluated the safety, administering up to 3 cycles who had completed the S cycle. And this was again 1:1 randomization. So in terms of study treatment, the NEPA, IV plus Palo, Dex were mixed and infused together Fosaprepitant was infused separately from palo and dex due to potential risk of incompatibility of fosaprepitant with palonosetron. And the study drugs were all administered through peripheral IV. These are the details of the administration. And in terms of results, complete response rates were non-inferior to fosaprepitant. Overall CR rate, which was the primary endpoint, was 75% with the IV NEPA-based regimen, 71% with the fosaprepitant-based regimen. The CR rates during acute delayed and beyond delayed, which is beyond 120 hours, and 0 to 168 hours were numerically higher with the IV NEPA versus the IV fosaprepitant-based regimens. In terms of efficacy, the hazard ratio for time to treatment failure was not significant between the two treatment arms. It was 0.78. In terms of safety injection reactions, the proportion of patients who developed injection site reactions were significantly lower with the IV NEPA versus the IV fosaprepitant, 11% versus 20% for AEs, and 0.3 versus 3.6 for treatment-related AEs. And this is what we see in the table below. The results of this exploratory analysis is what we see in terms of the CR rate during the extended overall phase. And in conclusion, IV NEPA with its dual anti-emetic action does offer additional convenience to clinicians. It is bioequivalent and comparable in safety and efficacy to oral NEPA. The liquid formulation, which is available in our country now, ensures that there is no reconstitution which is required. So the ease of preparation and administration is there for the healthcare providers. It does have significant efficacy in acute and delayed nausea vomiting control, which is comparable to fosaprepitant, but there are significantly better complete response rate during the extended interval up to 168 hours. And there's no hypersensitivity reactions and infusion site related adverse events, which were very significantly lower than as those compared to fosaprepitant. I thank you all for a patient listening.
Thank you so much, Dr. Advait, for such an instructive session. Now, our next session is supported by AstraZeneca, and I would like to call Dr. J.K. Singh sir to invite our next speaker.
This is the last topic of this particular session, and the topic is experience sharing on durvalumab in ES-SCLC, and the speaker is Dr. Devbrat Arya. He is a very renowned oncologist, medical oncologist. He is a senior consultant, and at present he is at International Oncology Center, Fortis Hospital, Noida. I think these are the topics which we face every day in our clinical practice. And I really congratulate Dr. Sumant Gupta for bringing these topics in this webinar. And I'm sure the learned speaker will enlighten us about this particular drug, which is very much effective in ES-SCLC. So with this, I will invite the speaker for his presentation.
So thank you, Dr. Singh, for that introduction. Thank you very much, Dr. Sumant, for this opportunity to be able to talk about this very promising drug. And thank you, AZ, for inviting me. So I have moved to Max Hackett. It's been 5 years, so I'm currently at Max Hackett, and just to update everyone. So the topic today, as Dr. Singh was saying, is about a disease which is very challenging in our clinical practice. So extensive stage small cell lung cancer is a disease which we often see. It compromises about 15 to 20% of all lung cancers. And when we look at when you talk about stage limited and extensive, I think a majority of our patients in an Indian setting are extensive stage small cell lung cancer. Next slide, please. Now, what we know from, can I have the next slide, please? Now, so what we know from the historical data is, while these tumors are very fast growing, they respond very well to chemotherapy as well. But unfortunately, then they recur very quickly, and to the first line chemotherapy regimen, the progression-free survivals are as short as a few months, 3 to 4 months. And the median or survival for patients with extensive stage small cell lung cancer is about 10 to 12 months, and very dismal, even for those patients who are quite fit at the time of presentation. Now, for many decades, the standard of care has been a platinum-based chemotherapy. The initial regimens used a lot of drugs. The subsequent standard of care became a doxorubicin, cyclophosphamide, vincristine, or an epirubicin, cyclophosphamide, vincristine combo regimen, until in the late 80s when the platinum etoposide based combination became the standard of care, and it remained the standard of care for nearly 3 decades. And while there was a lot of interest around maintenance chemotherapy, switch alternating chemotherapy, there was this false hope of platinum irinotecan based regimen through the Japanese oncology group studies, suggesting that perhaps that was better than the platinum etoposide. But unfortunately, most studies suggested that platinum etoposide was perhaps the best that we had, and it wasn't very good. So, so there has been a constant endeavor to look at other treatment options, and immunotherapy being one. And before I talk about that topic, I want to present this case, which is to generate interest. So this is about a 35-year-old man. Now, this is admittedly a little young age to have a small cell lung cancer, but he did complain of change in voice, which slowly progressed to aphonia. He, at his age, did not have any comorbidities, but had a significant smoking history. And in 2020, when he had these problems, he visited an ENT and was diagnosed to have a vocal cord palsy, underwent a CT scan of head, neck, chest, brain. Next slide, please. Can I have the next slide? So this showed a small, mild, enhancing soft tissue lesion with surrounding fibrosis in the apex of the left lung. And then there were also enlarged conglomerate necrotic lymph nodes in the left hilar paratracheal parasuvage region. And there were also a nodal mass in the aortopulmonary window compressing the left pulmonary artery. So looking at this picture certainly looks something sinister. Next slide. And something that possibly could escalate, a chance of there being a malignancy. But unfortunately, as is want in our country, the patient was started on anti-tubercular treatment. However, his condition worsened. Thereafter, a few months later, the patient had a seizure and he got treatment. And then he was asked to get a follow-up MRI brain. Next slide, please. So unfortunately, the MRI confirmed the worst fears. There were enhancing lesion in the right temporal lobe with surrounding edema without appreciable mass effect on the MR brain. And there were also multiple subcentric size lesions in the other parts of the brain, which included lateral temporal and fronto-temporoparietal region of the left side. Next slide. So at this time, considering his history of anomaly found in the CT scan, a CT scan of the thorax was repeated, and which revealed that there was a space-occupying lesion in the left upper lobe with mediastinal extension and encasement of the left pulmonary artery. Unfortunately, it also showed mediastinal lymphadenopathy and as well as surrounding consolidation. Next slide, please. So this is the PET scan. Yeah, so this is the PET scan. And on the image below, you can clearly see a large lesion in the left lung, which is encasing the, which is invading the mediastinum and encasing the major pulmonary artery. Next slide, please. And you can also see the enlarged mediastinal nodes. On the rightmost side, you can see the lesions in the brain, on the brain MR. Next slide. And eventually a biopsy was done. It showed a small cell neuroendocrine carcinoma. Interestingly, a PDL1 was also done, and the TPS was 3 to 4%. Next slide. So the final diagnosis was extensive stage small cell lung carcinoma with brain mets. Next slide. So the question was, what next? What do you do? What is the best way to treat? Is it systemic therapy? Is it radiation followed by systemic therapy? Do you do chemotherapy plus immunotherapy? Next slide, please. Now, what we've come to understand is, small cell lung cancer is a fast-growing disease, and so are its metastases. I think the general convention has been that for symptomatic patients, there is no doubt that radiation to the brain takes primacy, and that's what we initiate most of our patients on. And this is followed by systemic therapy. Now, there's also this thought process that those patients who have asymptomatic brain metastasis at the time of presentation, that's the situation where one may not do radiation to the brain. One may actually start with systemic therapy upfront and treat them if and when needed. But I think in most of our settings, especially with some of our patients coming from far away, even in the asymptomatic setting, while the practice in the world may be slightly different, in our cases, sometimes one may start with upfront radiation even in asymptomatic cases. Now, what we know for sure is that whole brain RT is beneficial, and whole brain RT is what is attempted. However, there is some interest around the role of stereotactic radiation. Now, we know typically small cell lung cancer would recur in multiple areas of the brain, and that's why whole brain radiation is what is preferred. But there's some data, very early phase data, to suggest that SBRT may also be useful, although with the caveat that there's never been a head-to-head comparison of whole brain RT versus SBRT in the setting of small cell lung cancer. Next slide, please. So this is again the NCCN guideline on small cell lung cancer presenting with brain mets, and clearly dividing patients into asymptomatic and symptomatic, and suggesting that one may administer systemic therapy before brain radiation, and the radiation may be done after completion of the induction systemic therapy. But for symptomatic situation, clearly brain RT is what we begin with, and this is then followed by systemic therapy. Next slide, please. So coming back to the topic of chemotherapy, and as I was earlier saying, platinum-based chemotherapy has now become the standard of care. We know that while a significant number of these patients who receive a platinum-based chemotherapy will have a response. So when you look at different studies, the response rate would vary between 60 to 80%. The median PFS ranges in between 4 to 6 months, but unfortunately, the median overall survival remains very dismally low at around 9 to 11 months. Also has been an interest around addition of a third chemotherapy regimen or maintenance chemotherapy, but unfortunately, none of these strategies has yielded an overall survival benefit. Next slide, please. So coming back to this patient was initially started on chemotherapy, etoposide and cisplatin. Now, we know platinum etoposide being the standard for a lot of young fit patients, cisplatin would be used. But for a significant number of patients who are older and patients similar to what we see in our real world practice, I think the go-to regimen for a lot of us is a carboplatin-based regimen, carboplatin etoposide, on account of the fact that carboplatin is much easier to administer. There is less nephrotoxicity, less ototoxicity, less neurotoxicity, although there may be a little bit more myelosuppression. But this patient being young was started on cisplatin. At the same time also received whole brain radiation. with hippocampal sparing, followed by some boost to the gross lesions. Next slide. Next slide, please. So, when it came to the preferred chemotherapy regimen, these are the different chemotherapy regimens. But what has happened in the past few years, and I would say past 3 to 4 years, is the advent of immunotherapy. And I think immunotherapy has added somewhat to the armamentarium that we have in terms of systemic treatment for extensive stage small cell lung cancer. Next slide, please. So, can I have the next slide, please? So, one of the first drugs that was evaluated was nivolumab, either alone or with ipilimumab, and typically as maintenance. Unfortunately, the maintenance strategy failed. So, where these patients would have received induction chemotherapy, a platinum etoposide, maintenance with the anti-PD-L1 failed. Some of the next studies evaluated the combination of platinum etoposide along with ipilimumab, which is the anti-CTLA4. Unfortunately, this strategy also failed to yield any advantage in terms of median progression-free survival or overall survival. And there was also the strategy of induction platinum-based chemotherapy followed by pembro maintenance, and that also unfortunately failed till we had first the studies, the results from the IMPAR 133, which looked at atezolizumab in combination with platinum etoposide, and subsequently the results from the Caspian trial, which looked at durvalumab along with platinum and etoposide. There was another arm which looked at durvalumab plus tremelimumab along with platinum etoposide. But the durvalumab arm showing benefit, which we are going to discuss in the coming few slides. And durvalumab was not only approved, it became the standard of care. And from cycle 3 onwards, the patient, along with chemotherapy, also received durvalumab. Next slide, please. So, why is immuno important? I think all of us now understand the basis, the mechanism of action of immunotherapy. What we also know from our experience of chemo-immuno combination across different solid tumors is that the chemotherapy-induced tumor cell killing may induce tumor antigens release, which may make the tumor more immunogenic, and therefore the immunotherapy, when added to chemotherapy as a combination, may have synergistic effects in terms of the control of tumor growth, and then may lead to an improvement in efficacy of the combination, leading to not only an improvement in PFS but also OS. Next slide, please. Next slide, please. So, Caspian was the first and perhaps the only approved immuno-oncology drug, which has looked at extensive stage small cell lung cancer, where patients in the control arm could receive either cis or carboplatin up to 6 cycles. So this is the trial schema, and I'll briefly discuss this. So the study included newly diagnosed extensive stage small cell lung cancer. The patient needed to be fit with a PS of 0.1, life expectancy of at least 12 weeks, had to have at least one target lesion. They could receive either cisplatin or carboplatin, and this was one of the stratification factors. And the randomization was in the induction phase into 3 arms. One was durvalumab, that is Imfinzi, along with platinum etoposide. When Imfinzi was given, it was given at a dose of 1500 mg once every 3 weeks, along with cisplatin or carboplatin for up to 4 cycles. And those patients who did not have a progression would then have a maintenance phase, which had durvalumab at 1500 mg once every month until disease progression. And this was compared to the control arm, which was a platinum etoposide, so carboplatin or cisplatin based on the investigator's choice, along with etoposide for 4 to 6 cycles. So in the control arm, the patient could receive up to 6 cycles. And then there was a third arm, which looked at durvalumab and the investigational agent tremelimumab. Now, very importantly, the primary endpoint of this trial was overall survival. There were other key secondary endpoints, which included progression-free survival, overall response rates, survival at 18 months, PFS at 6 and 12 months, so important milestone analysis, and the HR related quality of life. Now, what's important is Caspian, in contrast to IMPAR 133, which looked at atezo along with platinum etoposide, allowed the investigator to choose their platinum. So in IMPAR 133, the drug of choice was carboplatin, whereas in Caspian, investigator could use cisplatin instead of carboplatin. The patients with asymptomatic or treated brain mets were included in this study. The control arm could have patients receiving up to 6 cycles of chemotherapy, and PCI could be administered in the control arm as per the discretion of the treating physician. Next slide, please. So, key differences, as I said earlier, there were no biomarker-based selection. So, the patient didn't need to have a PDL1 or TMB to be included. All comers were included. Untreated brain metastases were included in this trial in contradistinction to those in the IMPAR 133 study where they were excluded. PCI was allowed in the control arm, and a significant number of these patients did receive PCI. PCI was not allowed in the experimental arm in Caspian, and the one reason for that is at least at the time of study, they were not sure whether durvalumab was safe to be administered along with cranial radiation. Unlike IMPAR 133, where the control arm allowed for only 4 cycles of platinum etoposide. In Caspian, patients could receive up to 6 cycles. And as I said, carboplatin along with cisplatin were both included. Now, what's very important is that this inclusion criteria is very reflective of the real world clinical practice. So a lot of patients who come to me and who are not able to afford immunotherapy, the description and the explanation is 4 to 6 cycles. And most of us actually tend to go up to 6 cycles of platinum etoposide based therapy, especially for those patients who are responding and tolerating. And again, a lot of these patients who have asymptomatic untreated brain mets would be there. Up to 10% of small cell lung cancer patients have brain mets at baseline, and I think it's very important for any study which is evaluating a new drug to actually evaluate the new drug in this significant population of patients as well. Next slide, please. So these were the salient aspects of the design. So durvalumab, importantly, during the induction phase was once every 3 weeks, and in the maintenance phase was slightly easier, once every 4 weeks. Both cisplatin and carboplatin were allowed. OS, importantly, was the primary endpoint. Control arm could receive up to 6 cycles of platinum-based therapy, which reflects clinical practice. PCI was an option that was there for the control arm, and asymptomatic as well as treated and stable brain met patients were included. Next slide, please. So what were the results? Now, when you look at overall survival, and we look at overall survival, durvalumab in combination with platinum etoposide consistently improved overall survival compared to control, regardless of absence of brain mets. So when you look at the slide on the left-hand side are the curves for those patients with brain mets. And you can clearly say that those patients who have brain mets, the median OS for this subgroup on platinum etoposide was 8.8 months, which got increased to 12 months for the durvalumab arm. And on the right-hand side, you can see those patients who do not have brain mets. Again, a statistically significant improvement in survival from 10.5 months for the non-immuno arm to 13.0 months for. Next slide, please. What about progression-free survival? The progression-free survival was higher with durvalumab arm compared to platinum etoposide. And when you do the milestone analysis, so the hazard ratio for the median PFS was 0.80 now. If you look at the figures, the median PFS for durval looks 5 compared to 5.4, but This is an immunotherapy trial, and therefore the hazard ratio is not going to be proportionate. But when you look at the milestone analysis at 1 year, 5.3% of patients on the chemo arm were progression-free compared to 17.9% in the immuno arm. And look at how the curve tails out. And at 2 years in the immunotherapy arm, and this is a post-hoc analysis, 11% of patients are progression-free in the durvalumab arm compared to just 3% or thereabouts in the chemotherapy arm. So this is very important. 9.1% of patients who actually were started on durvalumab, that's Imfinzi, have been on the drug for more than 3 years. And this I think is very important and reflects how the curve is tailing and how some of these patients will derive a benefit which is going to be very long lasting. Next slide, please. So what about overall survival in the entire cohort? Clearly, overall survival was higher, 10.5 months in the chemo arm compared to 12.9 months in the chemo immuno arm. Again, when we look at the milestone analysis at 1 year, 52.8% of patients alive in the durvalumab arm compared to 39% in the chemo arm. And as time passes by, the curves continue to separate. So at 2 years, the corresponding figures 23% alive in durvalumab arm compared to 14% in the chemo arm, and at 3 years, 17.6% of patients in the durvalumab arm alive compared to just about 6% in the chemotherapy arm. So clear, sustained separation of curves, and with a significant flattening from around 2.5 years timeline, which supports that the long-term OS benefit is actually a sustained OS benefit in this fraction of patients. Next slide, please. Can I have the next slide? Yeah. So when you look at different analysis, I think look at overall response rates, consistent improvement in overall response rate. So nearly 68% of patients in the durvalumab arm showing a response compared to 58%. And the duration of response was also, when you look at the milestone analysis, nearly 22.7% patients in the durvalumab arm continue to have a response compared to 6.3% in the chemotherapy arm. Next slide, please. So based on this data, Imfinzi, that is durvalumab, was approved, and it's in fact the first approved immuno-oncology drug to improve both response rates and the durability of response at 2 years. Remember, atezolizumab, the IMPAR 133 study, the response rate in both the chemo-immuno versus the chemo arm were similar, but unlike that study, clearly Caspian showing that the addition of durvalumab led to an improvement in response rates with a delta of 10%. Next slide, please. So back to our case, follow-up PET scan was done. The patient had already received radiation, also had received chemotherapy and then immunotherapy. Next slide, please. And clearly the scan showing a good response. So look at the image of the PET scan. So just try and remember there was a large lesion in the apex of the left lung, which was invading the mediastinum, and we are clearly able to see here that the lesion seems to have cleared out. Thanks to radiation, the brain mets also appear to have cleared out. Next slide, please. Next slide, please. So the patient continued on immunotherapy, and the patient continued to have sustained response to immunotherapy with persistent reduction in the size of the lesions. Next slide, please. Can I have the next slide? Yeah. So again, just to highlight the point that in the maintenance phase, durvalumab is the only drug that can be given once every 4 weeks. The regimen for the other immuno-oncology drugs that have been approved are slightly more tedious. Remember, there are 2 other drugs on the serpillimab and adalimumab, which have also been evaluated now with chemotherapy and showing some benefit. and we are going to keenly await the full text publication for these drugs as well. Next slide, please. One of the cost effectiveness analysis actually showing that durvalumab was more cost effective compared to atezolizumab in this setting. Next slide. So I'll quickly conclude by saying that the combination of durvalumab along with platinum etoposide is the new standard of care in the first-line treatment of extensive stage small cell lung cancer. It has shown sustained improvement in overall survival compared to a robust control arm that actually could receive up to 6 cycles of platinum etoposide. So a control arm receiving therapy which reflects the practice in the real world setting. It actually allows the flexibility to the clinician to use either cisplatin or carboplatin. The benefit of additional durvalumab was observed across different subgroups. More than 17% of patients on durvalumab were alive at 3 years, and I think that's a while the figure is still low, it's certainly compared to the historical data an astounding figure. The combination is associated with a high response rate. The regimen administration is quite convenient in the maintenance phase once a month, and the safety findings remain consistent with what we know about durvalumab. Next slide, please. So with that, I thank you all for your patient hearing, and back to the organizers, back to Dr. J.K. Singh. Thank you very much.
Thank you so much, Dr. Arya, for such a nice presentation. Now let us move on to our next session, which is supported by Viatris. And for that, I would like to again call Dr. J.K. Singh, sir, to invite our speaker.
I think the topic for the next presentation is liposomal amphotericin B in the management of invasive fungal infections. And the speaker is Dr. Pawan Kumar Singh. He is consultant, Department of Hematology, BLK Max Super Specialty Hospital, Gurgaon. Friends, the incidence of invasive fungal infection has been found very frequently in cancer patients whenever we treat such type of patients. Early and accurate diagnosis are very important since mortality is higher in untreated or not appropriately treated patients. Recently, we have been witnessing that the usual antifungal agents which we have been using has become resistant for antifungal prophylaxis. Now we need some more potent and less toxic antifungal agents, which is required to control such type of resistant infection. I think Dr. Pawan is a very renowned medical oncologist, and he will address the issues related to early diagnosis and latest advancement in the management for these problems. Dr. Pawan, I will invite you for your presentation, please.
Thank you, sir. Thank you, organizers, and thank you, Dr. J.K. Singh, sir, for inviting me for this talk. So, are my slides visible and am I audible?
Yes, you are.
Okay, thank you, sir. So, invasive fungal infection, yes, we do see a lot, especially in poor socioeconomic status patient, and a lot of constructions and dust pollution and all these things going on, and leading to more invasive fungal infection nowadays in our set of patients, immunocompromised patients. So the slides have been provided to me by Mylan Viatris. Made some changes. So antifungal therapies, if we see in last 60 years, the earliest or the first antifungal agent is the amphotericin B deoxycholate, or the conventional form of amphotericin is still being used, and we also use, though it has its own limitations by nephrotoxicity and infusional reactions. Then other are the flucytosine, azoles. Azoles came in early 90s. Then lipid formulation of amphotericin B, it has again the spectrum was broad, and the side effect profile is better. So these came in again in early 90s, and after that in early 2000, echinocandins, and then the second generation azoles, and now we see like voriconazole, isoconazole, and other azoles. So not many antifungal agent, but still we are able to control fungal infection with the help of these antifungal agents. So amphotericin B, it is basically it's a polyene antibiotic, and it is the oldest family of antifungal agents, and it is the advantage of amphotericin B is that it has the broadest spectrum of activity and very low resistance rate, and it has good clinical and pharmacological action. And it is another advantage of amphotericin B over other antifungal agents is the rapidity of action. So it has some side effects. The most important one is the nephrotoxicity and infusional reactions. So that lead to some limited use. And to overcome these complications, new formulations of amphotericin B have been developed. So one is the amphotericin ABLC, or the amphotericin B lipid complex. Then other one is the liposomal amphotericin B. Then ABCD, amphotericin B colloidal dispersion. It has now been discontinued due to high rate of infusional reactions occurring with these agents as well. And amphotericin B, it is the treatment of choice for many serious fungal infection in immunocompromised patient because of the extended spectrum and low resistance and the rapidity of action as well. So what is liposomal amphotericin B? Liposomal basically it is composed of phospholipid bilayer. So this bilayer lipose and the drug is conjugated inside of this liposome, and it has a size of around 60 to 80 nanomoles, nanometer, and that causes slow release of drug. And this liposome is taken up by the macrophages of the reticuloendothelial cells, and from there the advantage of this liposomal is that the delivery of drug is usually at the targeted site, and affinity of this to the fungal ergosterol is greater than mammalian cholesterol, and it is drug released only in the presence of fungal cells. So in preclinical studies, liposomal amphotericin B mechanism of action resulted in potent in vitro fungicidal activity, and the integrity of liposome is maintained in the presence of mammalian cells, reducing its toxicity. Pharmacokinetic properties and the effect of toxicity of different lipid formulations. So the AUC of amphotericin B, when it is given as liposomal amphotericin B, increased in a manner greater than the incremental dose increase. And high Cmax ensures the amphotericin delivered as liposomal form has a long circulation half-life, and it acts as the reservoir in the plasma from where it is distributed into the tissues. So that's how it increases the Cmax value. And the volume of distribution again is significantly reduced with liposomal amphotericin B, allowing for greater drug concentration in the plasma. So pharmacokinetic properties parameters suggest that amphotericin B remains associated with liposome structure while in circulation when delivered as liposomal amphotericin B. So this is a comparative table of comparison of liposomal amphotericin B with ABLC, or the colloidal dispersion formulation. So here the biochemical and pharmacokinetic differences between different amphotericin B formulation. So this liposomal amphotericin B, it is a small unilamellar vesicles. So here in ABLC it is ribbon-like structure, and in colloidal dispersion they are present in micelles form. So AUC is, we can see here that AUC is more for liposomal amphotericin B. Then high Cmax, high AUC, and low clearance rate. Liposomal amphotericin B, it is mostly associated with liposomes in circulation, and minimal drug transfer to mammalian cells. That's why leading to longer in circulation before it is taken up by the reticuloendothelial cells. Now, the most important part is the impact on the toxicity and efficacy. The reduced renal clearance due to intact liposomal. So it is not dissociated amphotericin B. So that is how it leads to less nephrotoxicity profile as compared to free amphotericin B, because it is present into the liposome. And clinically achievable AUC values associated with near complete suppression of galactomannan in these steady beta-D glucan levels. These are the markers of therapeutic response in invasive pulmonary aspergillosis. So structure of this liposomal amphotericin B is in such a way that it leads to decreased toxicity profile of the drug. Infusion reactions. So these are the this is comparison between liposomal amphotericin B and the conventional amphotericin B. So here we see that fever, the incidence of fever is more with the conventional form as compared to the liposomal form, and so is the chills and rigors of the other infusional reactions. Now, day one infusion related adverse event, again in ABLC and liposomal amphotericin B. So here, this is the blue one is the liposomal amphotericin B given as 3 milligram per kg per day. This is liposomal amphotericin B, and it is the ABLC. So here also in liposomal amphotericin B, 3 and 5 milligram concentration, 5 milligram per kg dose, the risk of fever and chills and rigor, they were less as compared to amphotericin B lipid complex. Nephrotoxicity profile in this study also, the nephrotoxicity profile in when it is measured by serum creatinine value more than 2 times the baseline or the more than 3 times the baseline, both were less with liposomal amphotericin B when it was compared to conventional amphotericin B, and similarly with amphotericin B lipid complex when liposomal was compared with amphotericin B lipid complex. Now, drug discontinuation due to toxicity in amphotericin B lipid complex or the liposomal amphotericin B. So this is 3 and 4. The discontinuation rates were also less when liposomal amphotericin B used both in concentration of at a dose of 3 milligram per kg or 5 milligram per kg compared to amphotericin B lipid complex. Safety and efficacy studies. So this is the efficacy of amphotericin B formulations. So systematic review and meta-analysis of 23 randomized controlled trials, the efficacy of all amphotericin B formulations was similar. So efficacy wise, if we see, almost all the formulations have similar efficacy. The lipid-based formulations of liposomal amphotericin B compared to conventional amphotericin B, it provides fewer nephrotoxicity, fewer infusional reactions in terms of fever, chills, and vomiting. So this is the odds ratio. Conventional amphotericin B, it presents a similar efficacy profile as lipid-based formulations, although the safety profile is better with other lipid-based formulations. So this is the comparative study of efficacy-wise liposomal amphotericin B at a dose of 3 milligram per kg, liposomal amphotericin B at a dose of 6 milligram per kg, compared with conventional amphotericin B at a dose of 0.7 milligram per kg. And in this study, it was found that liposomal amphotericin B, it provides equal efficacious alternative to conventional amphotericin B in patients with HIV and acute cryptococcal meningitis when it was given at a dose of 3 milligram per kg, and it is associated with fewer side effects as well. So in the treatment of neutropenia associated fever, so in neutropenic patients with documented or suspected invasive fungal infection, liposomal amphotericin B given as a dose of 5 milligram per kg was superior to conventional amphotericin B when it was given as 1 milligram per kg with respect to both efficacy and safety. So we can see that response rates at day 14 at completion of therapy and the mortality rates were less in liposomal amphotericin B as compared to conventional amphotericin B formulation. So when it was given empirically for the pyrexia of unknown origin in neutropenic patients, so in this, when liposomal amphotericin B given as 1 milligram per kg as 3 milligram per kg with comparison with conventional amphotericin B at a dose of 1 milligram per kg, the drug-related adverse event and the serious adverse drug-related events were seen in the usual adverse events are more with conventional amphotericin B, and serious adverse events with liposomal amphotericin B were almost nil. again a double-blind multi-center trial of liposomal amphotericin B with conventional amphotericin B. So here also we can see that the success rate is approximately 50%. So it is almost comparable in both the liposomal and conventional form, but the discontinuation rates here we can say it was more in conventional amphotericin B as compared to liposomal amphotericin B. So renal outcomes in patient with treated with the 4 different combinations or formulation of amphotericin B. It is a prospective study of 480 patients. So the nephrotoxicity predictor included formulation type and duration of treatment. So compared with patients without nephrotoxicity, patient with nephrotoxicity had a numerical higher mortality rate, and their mean length of stay in the hospital was prolonged by 8.6 days. Creatinine level increase developed in fewer patients receiving liposomal amphotericin B as compared to conventional or other lipid formulations of amphotericin B. So again, this retrospective study of conventional amphotericin B with liposomal or ABLC and use of liposomal amphotericin B was found to be independent protective factor for nephrotoxicity with odds ratio of 0.18, and mortality ratio also is less. So here we can see that liposomal amphotericin B has associated with better outcome than other formulation, including severe nephrotoxicity and overall mortality also. So ABLC in empirical treatment of febrile neutropenia, here also we can say that adverse events are more with the conventional form as compared to other uh, doses of liposomal amphotericin B when it was given as at a dose of 3 or 5 milligram per kg, and it was mortality was higher in patient with ABLC than those treated with 5 milligram per kg of liposomal amphotericin B. So this retrospective analysis of patient with renal insufficiency or previous toxicity of conventional amphotericin B receiving ABLC or liposomal amphotericin B. So liposomal formulation has less nephrotoxicity, lesser infusion reactions and hypomagnesemia as compared to other formulation of amphotericin B, that is the ABLC, in patients who are at increased risk of nephrotoxicity. Now, the spectrum of activity of antifungal agents. So here we can see that amphotericin B, whether it is in conventional form or liposomal form, it has broadest spectrum of activity against all the antifungal, fungal infections like Candida, whether it is albicans or non-albicans Candida, then Aspergillus, Cryptococcus, Mucorales, and the other blastomycosis or coccidiomycosis, even histoplasmos. So you can see that it has the broadest spectrum of activity. Now coming to antifungal resistance, it is a growing problem, particularly uh, to the Candida, and it is associated with poorer outcome. Azole resistance is growing in Aspergillus. Also, we can see a lot of reactivation of patient not responding Aspergillus pneumonia invasive fungal infection because of Aspergillus, and they are becoming more and more resistant to voriconazole. So pre-exposure to antifungal agents, it causes increased risk of resistance, but liposomal amphotericin B is recommended for suspected resistant Aspergillus or for breakthrough fungal infection after azoles, and it is the first choice treatment for mucormycosis also. So minimal resistance is reported with polines, that is the amphotericin B. Echinocandidates, again, some resistance is still getting prevalent. But with azoles, the highest rate of resistance is against the azoles, particularly fluconazole in non-albicans Candida. Now, the guidelines. So guidelines, IDSA 2016 guidelines. And so these are for non-neutropenic ICU patients. Liposomal amphotericin B, it is strongly recommended for with low quality evidence where intolerance or resistance to other agents. So in those situations, we can give liposomal amphotericin B. So for high risk prolonged neutropenic patients, strong recommendation, B1 recommendation is there with high quality of evidence available. Now, again, ambisome or the liposomal amphotericin B, strong recommendation with moderate quality of evidence as per ESC MID ECMM, ERS, or EACL, IDSA for the treatment of invasive aspergillosis, especially in azole resistance cases, B2 and B2 recommendation in neutropenic patients. Now, for invasive candidiasis, A1 and A2 recommendation for hematological malignancy in overall population, strong recommendation with high quality of evidence available for non-neutropenic and neutropenic patients also. For mucormycosis, B2 recommendation, A2 overall population if you see, and with CNS involvement, A3 recommendation, and solid organ transplant also A3 recommendation. So finally, to conclude, it is considered as gold standard treatment for invasive fungal infection, mainly because of the broad spectrum of activity, reduced toxicity, low resistance rate, and excellent clinical and pharmacological action. And one more thing is the rapidity of response. And it is strongly recommended as empirical therapy for presumed fungal infection, both by SL and BCSH guidelines. And the formulations are approved for pediatric use as well for kids more than 1 month of age, and continues to play an important role in empirical management of invasive fungal infection. Despite several other drugs like recent azoles, isavuconazole, and echinocandins classes, but still it is considered as empirical management for invasive fungal. So I would like to stop here. Thank you.
Thank you, Dr. Pawan, for your wonderful presentation. And that is on liposomal amphotericin B drug. And for a long time, we have been using this drug and we are finding it very effective. Thank you once again for your presentation. And with this, we conclude this particular session. Thank you.
Thank you so much,
Over
Dr.
to the
J.K. Singh,
organizers.
sir, for chairing the session so wonderfully. And thank you, Dr. Pawan, sir, for giving such a nice presentation. Now let us move on to our next session, which is on lung cancer. And for that, I would like to welcome our chairperson, Dr. Arvind Krishnamurthy, who is secretary in ISO, professor and head in Department of Surgical Oncology, Adyar Cancer Institute, Chennai. And our next session is supported by Jensen Oncology. Thank you, and over to you, sir.
Yeah, good evening, everybody. I think my pleasure to be associated with the Oncology Review 2022, and especially this session as well. We've had some interesting talks, and now we are looking forward for another interesting perspective from Dr. Nagendra Sharma, who is an associate consultant medical oncologist at the Medanta Medicity Gurugram. And he will be talking about the hidden EGFR threat of NLCLC, and very specifically with regards to exon 20 insertions. And we know that EGFR mutations have actually changed the landscape of the way in which we treat advanced lung cancers, and exon 20 insertion seems to have its own story in the traditional drugs being resistant. Of course, there are promise of newer drugs in the horizon, and I would sort of request Dr. Nagendra Sharma over the next 15 to 20 minutes to take us through this. Over to Nagendra.
Thank you very much, sir, for the kind introduction. And I want to, at the outset, I would like to thank Dr. Sumant Gupta for giving me the opportunity, and ISO, Indian Society of Oncology, who have conducted this webinar, and with the objective to review and present the key scientific learning in oncology from year 2022. So I would like to share my slides. I hope my slides are visible and my voice is audible.
Yes, Nagendra, go ahead, please.
Thank you. So the topic for today's presentation is exon 20 insertion and unmet need. Where are we in 2022 as of now? So we know that thoracic oncology, especially lung cancer, have undergone a rapid transformation and paradigm shift. So NSCLC, lung cancer, we know that the oncogenic driver mutations for EGFR typically occurs in exon 18, 19, 20, 21. Until recently, the EGFR-driven tumors were displaying sensitivity to EGFR TKIs. But right now, we are moving towards exon 20 and rare mutation like exon 18. So the topic for today's presentation, exon 20 insertion and unmet need. So this is the hospital where I work. presently. I'm a principal consultant in Department of Medical Oncology at Max Specialty Hospital, Saket, New Delhi. So NSCLC, it's not one disease. We know that it's a constellation of multiple diseases. The activating mutations occur in the cancer cell genes that encode the proteins critically to the cell growth and survival. And the malignant cells with activating mutations are uniquely susceptible to the target therapies. So we know that EGFR, nearly 35% of patients, KRAS 25%. In 24% of patients, we are not able to identify any oncological drivers. And ALK, we know that by and large 7.9%, and other rare mutations. So EGFR mutations are among the most prevalent actionable driver mutations in NSCLCs. So most common EGFR mutation in NSCLC, we know that the oncogenic mutations of EGFR are found on exon 18 to 21. It encodes part of tyrosine kinase domain around the ATP binding pockets of the enzyme. Exon 19 and exon 21 mutations are often referred to as a common EGFR activating mutations. So as you can see, by and large, exon 19 deletion is 44 to 47% of the patients of EGFR mutant NSCLCs. Exon 21, L858R, it is 32 to 45%. Then the third most common is exon 20 insertion, that is 1 to 12% of the patients, and others are around 10 or less than 10% of the patients. So EGFR mutation location determines the sensitivity to the TKI therapy. So unlike mutations of EGFR 18, exon 18, 19, 21, exon 20 mutations are typically resistant to EGFR TKI, with an exception of A763, Y764 insertion FQEA. This is the only exception which is sensitive to EGFR TKI. Otherwise, majority of the mutations are resistant to EGFR TKI. L858R and exon 19 deletion mutations cause conformation changes that confer sensitivity to EGFR TKIs. In contrast, exon 20 insertion mutations cause conformal changes that reduces TKI binding. For example, insertion after site 764 may form a wedge at the end of the helical region that locks it in the active site. There are low response rate, that is around 3 to 8%, have been reported in the patients with EGFR exon 20 insertion mutations treated by erlotinib, geftinib, or afatinib, that is first generation and second generation TKIs. So exon 20 insertion, what is the prevalence? The EGFR exon 20 insertions are the third most prevalent EGFR mutations after common mutation exon 19 deletions and L858R substitutions. And exon, the inframe insertion in exon 20 of the EGFR gene were among the first EGFR mutations to be identified as oncogenic drivers in NSCLCs and account for near about 12% of EGFR mutated NSCLC, as you can see clearly in this pie chart. EGFR exon 20 insertion, we know that the real world frequency of exon 20 insertion mutations varies and may be underestimated due to the limitations of the current testing methodologies. So in Asia Pacific region, by and large, you can see like China, the EGFR, all mutations are nearly 0.3 to 2.9, and EGFR mutant NSCLC is 2 to 5%, right? So Latin America, if you see, by and large, it is 1.3 to 2.1% of all NSCLCs. USA, it is 0.5 to 2.6% of all NSCLCs, and 5 to 12% of EGFR mutant NSCLCs. Europe, it is 0.3 to 1.3% of all NSCLCs between 13 studies. And for EGFR mutant, it is 4 to 12%. Asia Pacific, as already told, 0.1 to 4% in all NSCLCs. There are 28 studies to support that, and 1 to 5% of EGFR mutant NSCLCs, 16 studies. So why this is different? So EGFR exon 20 insertion, it is similar to common mutation of EGFR exon 20 insertion mutations are particularly prevalent in women, non-smoker, and those of Asian ethnicity and in adenocarcinoma subtype of NSCLCs. If we go into biology, EGFR exon 20 insertion encompasses a heterogeneous range of insertion located on the TKI domain of EGFR and prevents effective TKI binding. So as you can see, there are 3 regions. EGFR TKI domain, we can see there is for exon 20, the location like helical, near loop, and far loops are there. The most insertion typically occur between the amino acids 761 to 775 and can be divided into according to the protein structures they form, like helical, near loop, and far loop. So majority of these mutations which are occurring are in helical loop between 761 to 755, right? So exon 20 insertion are either in-frame insertion or duplications. Most insertions comprise 3 to 21 nucleotide base pairs, 1 to 7 amino acids, and the location of this insertion can influence the drug and ATP binding kinetics. There are broad number of EGFR exon 20 insertion variants. To date, over 100 unique variants of EGFR exon 20 mutations have been identified. Retrospective study says that P.A767, B769 duplication, and PS768.D770 duplications are most prevalent exon 20 insertion variants. So these are the most common as depicted in this picture. So these are the most two prevalent type of subtype of exon 20 insertion variants. So EGFR exon 20, what is the prevalence in biology? The EGFR exon 20 insertions are unique and distinct from common EGFR mutations. Compared to the common mutation, exon 20 insertion induces unique conformational changes in the EGFR and reduces the size of the drug binding pocket and affinity for the TKIs. So as you can see clearly, so this is because they are less sensitive to the EGFR TKIs. So limited treatment options. There are limited treatment options for this agent. The current treatment options have limited efficacy, highlighting the need for novel targeted treatment for patients with EGFR exon 20 insertion. So EGFR TKI have transformed the treatment landscape of EGFR mutated NSCLC. However, as we know already that exon 20 insertions are generally insensitive to EGFR TKI. Patients with exon 20 insertion have lower response rates to EGFR TKIs compared to those with common mutations. As you can see, the objective response rates for the common mutations is hovering around 65 or 67%. On the other side, for exon 20, it is very less. That is less than 27% in 35 and 32 also it is 27. Rest all it have shown very, very less response rates. So the systemic literature review of 78 studies were found that currently available EGFR TKI are generally ineffective against the EGFR exon 20 insertion. The objective response rate hovers around 20% or less than that. Median PFS is around 1.4 to 3 months, very small, with erlotinib, geftinib, and osimertinib treatment. As you can see, exon 20 insertion, the median also hovers around 4.8 to 19 months by and large, as depicted in 6 studies. Median PFS is 1.4 to 3 months, and objective response rate is 0 to 20%. That's why it is tough to treat, and there is unmet need. Platinum-based therapies are the most common first-line treatment for patients with EGFR exon 20 insertions. However, the responses are still not durable. The median also hovers around 17 to 18 months, and median PFS is around 5 to 6.5 months. So the real-world PFS in first-line treatment, like those patients who have been exposed to platinum-based chemotherapy in combination with IO agents, in real world, and there also they have not shown much survival benefit. In real world scenarios, there is no standard of care for second-line treatment with IO or and chemotherapy, having limited efficacy both alone or in combination, as you can see clearly. So this patients of EGFR exon 20 insertion carries a dismal or poor prognosis than those with common EGFR mutations. So there were real-world analysis of studies were done, and what they have found out to understand the unmet need for exon 20 insertion mutations in the real-world study was conducted in over 3,000 patients with EGFR and CLCs, with the objective to prognostically value the exon 20 insertion compared to the common EGFR mutations, and to find out the predictive value of exon 20 insertion compared with the common EGFR to the EGFR TKI treatment, and real-world characteristics, treatment patterns, and clinical outcomes of the patient with exon 20 insertion and CLC. So these patients were taken from the Flatiron database from January 2011 to May 2020, and all type of mutations were taken into consideration, and the treatment initiated within 19 days of advanced diagnosis. So the baseline characteristics were generally matched, and what they have found out is that the patient with exon 20 insertion had poor prognosis and 75% increased risk of death. So the study of 3,000 odd patients with advanced EGFR mutated NSCLC investigated the prognostic value of EGFR exon 20 insertion compared with common EGFR mutations like exon 19 and L858R exon 21 mutations. And you can see the real world overall survival is just 16.2 months for exon 20, and it is 25.5 months for common mutations. And the p-value is statistically significant, although hazard ratio is over 1.75. So what happens to the real world overall survival? That also is showing the PFS also is the same thing. The patients with exon 20 insertion had poor prognosis and 169% increased risk of progression or death to EGFR TKIs. The 5-year survival rate is just dismal, like it's just 8%, and it is 19% for those patients who are having common mutations. So by and large, the conclusion of this is that EGFR exon 20 have poor prognosis, 75% risk of death, 93% increased risk of progression or death, and 5-year survival is dismal, that is just 8%. So platinum-based therapies were the most common first-line treatment of exon 20 insertion NSCLCs with no clear standard of care in second-line options. Patients with exon 20 insertion derive less benefit from TKI compared with patients with common EGFR mutations, and 170% increased risk of death, 169% increased risk of progression or death. The poor outcome associated with exon 20 insertion and CLC illustrate the need for new effective therapies. So molecular testing and underdiagnosis, that also happens because of there is a highlighting the need of the comprehensive genomic testing is very, very important. So by and large, we are checking through PCR or NGS. The PCR analyzes particular gene variants at specific locations, can only detect predetermined target sequencing effective for lower target numbers and cheaper, and there are shorter turnaround time for PCR. This is the advantage. But NGS can detect a broad panel of mutations and gene fusions, can detect all variants without prior sequence knowledge, and is preferable for many greater than 20 targets, costlier, and longer turnaround time of around 18 to 21 days. Exon 20 insertion, as you can see, many PCR-based EGFR antigens only capture a small number of exon 20 insertion. That's why it is many times they will not be able to catch this up. This is what is depicted in this slide. So real-world analysis was conducted based on PCR and NGS, and the frequency of EGFR mutation and ability of NGS and PCR to predict them was also checked. It is projected that PCR-based assays will fail to identify 40 to 50% of EGFR exon 20 insertion in patients with NSCLC. This is a huge number. The PCR misses 49.1, nearly 50% of cases identified by NGS in Gini database. This is what was depicted. PCR misses 51.4% of cases identified NGS in FMI database. So Indian scenario, there are only few studies. The prevalence of exon 20 is around 1 to 8%. By and large, the latest one, which was published by N. Singh, was 5.4%, and the highest was debated by Dr. Norona V. et al. It is 8.8%. So there are two retrospective studies reported the efficacy and currently available treatment regimens for patients of EGFR mutations who carries poor prognosis. That is by Kether et al. And the same study have shown that by Dr. Norona V. et al., which have shown the median overall survival hovers around 5 months only for this mutation. So right now, where are we in 2022? So what is the latest update? Answer is we have got one first fully human EGFR MET bispecific antibody, that is amivantamab. This is a new treatment for this rare mutation. It is approved for the use in the patients with locally advanced or metastatic NSCLCs with activating exon 20 insertion mutations who have progressed on or after platinum-based chemotherapy. Based on phase 1, phase 2 Characilis trial, results amivantamab was granted accelerated approval by FDA in May 2021 last year. Amivantamab binds to extracellularly, so it is not affected by co-mutations in the EGFR TKI binding pockets, and by targeting, activating, and resistant EGFR mutations and MET mutations and amplification, amivantamab addresses two major mechanisms of resistance to standard of care. So mechanism of action, it has demonstrated three mechanisms of actions. One is that immune cell directing activity, second is receptor degradation, and third mechanism of action which is relevant to the ligand-driven disease, that is inhibition of the ligand binding. So dosing, as you can see, amivantamab is administered intravenously once weekly for 4 weeks, and then every 2 weeks thereafter. Due to the infusion-related reactions which can happen in the first dose, it is given through peripheral vein at first week, and through second week should be considered to minimize the drug exposure in case of infusion-related reactions. Infusion via central line may be administered for subsequent weeks. For less than 80 kg weight, the dose is 1050 ml. Each vial strength of 7 ml consists of 350 milligrams. That means 3 vials are required. If the weight is greater than 80 kg, that is 4 vials, 1400 milligram. So this is the way it have to be given. And Characilis, this is a phase 1 study of amivantamab in EGFR mutated NSCLC. It has got a very good tolerable safety profile considered with EGFR and MET inhibition. Treatment rated adverse events are grade 1 and grade 2 by and large, and the treatment discontinuation is only 4%. Amivantamab showed robust efficacy with objective response rate of 40%, median duration of response is 11.1 months, clinical benefit rate of 74%, median PFS of 8.3 months, and a median overall survival of 22.8 months, right? And amivantamab is the first bispecific antibody to demonstrate the clinically meaningful efficacy in patients with EGFR exon 20 insertions and NSCLC. Amivantamab could target either EGFR and or MET-driven tumors as monotherapy or in combination, given its favorable safety profile. There are so many other studies which have shown that this drug is a viable option, like mobocertinib, which is a TAC788, is a small molecule TKI that have designed to selectively target EGFR and HER2 exon 20 insertion mutations. Mobocertinib inhibits mutant EGFR and HER2 via covalent modification of EGFR cis797 and HER2 cis805. in the phase 1/2 study of mobocertinib, which is the oral pill of 160 milligram, demonstrated anti-tumor activity in patients with EGFR exon 20 insertion mutations, a manageable adverse event profile considered with other EGFR TKIs. And based on phase 1, phase 2 trial result, mobocertinib was granted breakthrough therapy designation by FDA in April 2020, 2 years back. Mobocertinib has been approved by FDA for the treatment of adult patients with locally advanced or metastatic NSCLC with EGFR exon 20 insertion mutations as detected by FDA-approved test whose disease has progressed on or after platinum-based chemotherapy. It is not upfront, it is those who have progressed on or after platinum-based chemotherapy. So mobocertinib inhibits oncogenic variants of EGFR and HER2. Mobocertinib inhibits EGFR and HER2 via covalent modifications of EGFR cis797S and HER2 cis805. It is binding intracellularly. Amivantamab was extracellularly, mobocertinib is intracellularly. Mobocertinib is oral, amivantamab is intravenous. Objective response rate is around 28. So this is on those patients who have been exposed to platinum prior. Disease control rate also is 78. And duration of response is around 7.4 to 20.3 months. For OS, you can see the median OS is 24 months and median PFS is 7.3 by and large. So efficacy outcomes of this drug also have shown that mobocertinib has safety profile that seems consistent with that of other EGFR TKIs, but has a higher rates of GI adverse events. 21% have experienced greater than 3 grade diarrhea. The clinical outcomes in the patients with or without adverse events leads to mobocertinib dose reductions in this subgroup. So by and large, this is a slide which is most important. I just want to take just 30 seconds on this. Amivantamab, the evidence of study was Characelis, cohort D, post-platinum patients. Mobocertinib is present phase 2, that is post-platinum exposure patients and exclaimed cohorts. And the clinical inclusion criteria was metastatic unresectable NSCLC with EGFR exon 20 insertion mutations and who have progressed on platinum-based chemotherapy. And mobocertinib also metastatic NSCLC with EGFR exon 20 mutations who have progressed on platinum-based chemotherapy. The dose, as you can see clearly, 1050, that is 3 vials in less than 80, 4 vials of 1400 milligram in more than 80 kg. First cycle is weekly, second cycle onwards is alternate weeks. Mobocertinib is standard dose of 160 milligram once a day in dose escalation and expansion or exploration cohort. So by and large, both the drugs are efficacious, and only thing is mobocertinib is famous for the GI side effects. Amivantamab is much better tolerable. The median oral survival, as you can see, mobocertinib is having a median oral survival of 24 months. Oral survival of amivantamab is 22.8 months. Median PFS of amivantamab is 8.3 months, and mobocertinib is 7.3 months. And the clinical benefit rate is around 74 for amivantamab, 78 by and large for mobocertinib. So at the end, I would like to thank the organizer for giving me the opportunity. So in oncology and advanced setting, the most important thing which you have to remember, the law of oncology says we have to keep these patients as good as possible for as long as possible. And in oncology, in advanced setting, remember that we have to cure sometimes, treat often, and comfort always. Thank you very much for patient listening. Over to organizers, please.
Yeah, thank you, Nagendra. I think these were the words of Dr. Shanta as well. You know, she in the Cancer Institute always used to tell us these words, and Nagendra was trained with us at the Cancer Institute, and very happy to see him sort of in a wonderful consultant position, and very nice to hear you, Nagendra. And in fact, I must tell you, in the last webinar conducted by the Indian Society of Oncology, we had sessions, or it was focused rather on molecular diagnostics and next-gen sequencing. And you rightly pointed out, I think, even in that webinar, we always said that, for broad-based sequencing, NGS, only then we would be able to detect these mutations in the first place. And of course, only then, of course, you really brought about the points of the 2 drugs on the exon 20 insertions. Promising data thus far. I hope that this comes in the first line at some point of time. Maybe logically it would come, but I think it's very important for us to diagnose these insertions and then treat them appropriately. I would like to thank also Sumant for wonderful organization for this sort of webinar, and also the MICE Ideas team, Rajesh, Priyanshi, and Siddharth. And thank you for the opportunity to be a chairperson. So I would hand it over back to the organizers for the remaining part of the program. Thank you.
Thank you.
Thank you so much, Dr. Nagendra, for such a great and explanatory session. Now I would request Dr. Anita Ramesh, ma'am, to moderate the session. And She is EC member in ISMPO and ISO, senior consultant in Department of Medical and Pediatric Oncology in Kaveri Hospital, Chennai. And our panelists are Dr. S. Krupashankar, Dr. Ravindra Ji, Dr. Aditya Murali, and Dr. Raghav Kesri. Thank you, and over to you, ma'am.
Yes, a very good evening. Priyankshi, can you see my slides?
Yes, ma'am, it is visible. Ma'am, can you do full screen?
It is.
All the slides are visible.
Okay. Okay. You can see the slides, no?
Yes, ma'am.
I don't know. Full screen is not coming because I had some issues with the. Okay.
Okay, ma'am, you can continue.
Okay. I don't know how to make it full screen.
You can do, ma'am, have you joined from phone? So you can,
Yeah.
Just tilt your phone screen so the slides will be visible. You can rotate your phone.
This rotation will do?
Yes, ma'am. Just try once.
I don't know. So just we'll continue. Oh.
Yes, ma'am. Go ahead. No issues.
Okay. Okay. Fine. So a very good evening, and I think we are also a little bit of behind time. We'll try to finish it on time. Okay. So it's a topic is also quite little different. Special situations beyond chemotherapy. Okay. So yes, as you know, lung cancer has taken a lot of lives. Remember, don't forget to talk about prevention. That is the smoking, and still now lung cancer. Even if whatever you say, you conclude it's a deadly disease as on today, and the 5-year survival remains quite poor. And though there are advances in the treatment, yes, we have gone a little way beyond, but still the number of deaths are high. But yes, we are able to give them a good progression-free survival and some overall survival benefit with some of the molecular studies. And if you see this busy slide on the milestones, which takes us quite a bit forward, and so too many tests and too many researchers and many drugs and many molecules to go about. So it's little crowded with too many things. So coming to this case study, 45 years, okay, had fever, difficulty in breathing, some chest pain. We did an imaging. These were the some of the pictures in the imaging. We start with Dr. Ravindra G from Bangalore. How will you approach to this patient for treatment? Dr. Ravindra or Dr. Raghav, anybody can take the question.
We will. Am I audible? I can see it's a plural based. Okay, sir. Sir, please go ahead.
No, yeah. Anybody can take either Dr. Ravindran or Dr. Raghav. Okay.
So we will do a biopsy of the lesion. Like, it's visible as a plural based lesion. It was like the slide. That is what it is visible to me. We can start with a biopsy of the lesion and we started from there then.
Yeah, a CT guided biopsy if it is more lesion. Okay.
I would prefer a PET guided biopsy because the lesion which is very active is peribronchial in nature. Possibly endobronchial biopsy would give me a better yield compared to a CT guided biopsy from the thorax or the chest wall. Because as a previous speaker said, previous panelist said, they want to do a CT guided biopsy. Probably a CT guided biopsy might not give me a good yield compared to peribronchial lesion which is more active. It can be easily obtained by endobronchial biopsy.
So it is more centrally, yes, endobronchial can be preferred. It is more peripheral, like the next slide, which you see, are more of a pleural based, okay, that a CT guided biopsy. And again, PET scan also guides us for the lesions, which gives you a better deal to point out the areas of high FDG uptake and taking. Okay, then coming to Dr. Aditya, what are the, after the biopsy sample has been given to you, so what are the tests that you would like to?
See, definitely to start with HPE and IHC for sure. The approach to any malignancies would be try and establish a complete histopathological diagnosis, which will need a IHC. Subsequent to that, we would probably want to do a staging investigation as well, like a PET scan or a whole body CT scan. And if it does seem like that it's a lung primary, which is an advanced primary, as in if there are centrally placed nodes, or in this case, since there is some central tumor also, maybe MRI of the brain as well.
Okay, if you are not doing a PET CT scan, then yes, MRI is needed. Okay, but histopathology, okay, coming to Dr. Kripa, just let's have a little more discussion about histopathology. Histochemistry would you like to do, or you don't do by default, and how do you do the other test?
I think, like Aditya rightly pointed out, we'll definitely have to do an IHC to understand, because we know you put it up as non-small cell, but it makes a difference for us to know whether it's adeno or squamous histology. So definitely for that, IHC is probably mandatorily done for all of our patients. So I think definitely yes, IHC is a must. Unless and until the pathologist can actually give us a report of an adenocarcinoma without doing an IHC, which is extremely rare. So I think IHC for sure, I think as a baseline for us to understand. Only then we would also want to do molecular testing. If it turns out to be an adenocarcinoma, then we would look at doing all the molecular testing like EGFR, ALK, BRAF, MET2, and so on and so forth. So I think for that as well, we would have to understand first that the histology is very important, and for that we will definitely need to look at the IHC.
Okay, fine. And there are different methods of biopsy. Now, quickly to this particular slide, when the patient is having effusion, okay, how do you proceed? Coming to Dr. Ravindra.
In case if the patient has got pleural effusion, possibly we usually do a pleurodesis. Before doing pleurodesis, we do a tapping of the pleural fluid, sent for cytology. And if cytology is malignant, again we might do a casting. And in case of the cast is done, then we subject that for IHC. That would be the course of action from our side. In case if there's a recurrent pleural effusion, which is going to happen more than 3 episodes, then we might advise the patient to undergo pleurodesis.
Okay, pleurodesis. And will you be able to do molecular testing on this pleural fluid? This patient also has ascites. Both.
Probably in case if the cell yield is more, we might try to do it. Unfortunately, in case if the cell yield is not adequate, possibly we may do a observed biopsy rather than depending on the pleural fluid cytology.
Yeah, sometimes this particular case, if there is no underlying solid SOL inside the lung, then yes, there are studies now, and many of the labs are also equipped. You have to take the entire pleural or the ascitic fluid out, go for cell block technique, spin the thing, and now technology has advanced so much with the residual cells. They are able now to do many of the immunohistochemistry, and I think some amount of the molecular studies are also possible in high-end lab. But what you said is correct. It's quite difficult. The yield will be many times less. Preferable if there is a solid mass SOL, better to take a biopsy from there. Coming to Raghav Keshwari. Yes, doctor. Do you do in a stage-wise format your molecular markers? Do you do limited markers, or do you do the big NGS panel? What are the things that you are doing?
Ma'am, if we do not have affordability issues, then in the current scenario, it is best to do go ahead with an NGS panel. But if those are the issues, then we go minimally with at least an EGFR AL cross PDL1. That is the minimum which we try to do. But if affordability is not the issue, then definitely NGS is a good option.
Okay, so the minimum markers is EGFR, ALK, and PDL1. Suppose this patient has also, not affordability is now. Coming to Dr. Aditya Murali. Okay, patient is NGS. Again, if you see the NGS is, if you see the NCCN as more guidelines, I think NCCN, to my knowledge, is not the first. They say do these markers, but they say that run the NGS with 350 genes, 650 genes. So if you have expanded panel, what are the other markers you would like to include in your panel? Limited. That's the
Thanks,
question.
Dr. Anita, for that question. So, by and large, at least in my own clinical practice, most advanced cases with non-small cell lung cancer, there is significant support from the industry in terms of the ability to do limited lung panels. Multiple labs in India are offering limited lung panels, and they do have all the markers which you have mentioned in your current slide. So for sure, there are other targetable mutations like ROS1, like BRAF-V600E, like RET, like MET amplification, so like HER2 as well. So for all of these mutations, there are targetable medications. So these ones for sure we would want. NTRK, irrespective of how rare they are, it's always good to have NTRK in the panel. I mean that would be, and KRAS also for sure. So I mean you have seen data of code break coming out, in the last 2-3 days. JCO has come up with a living practice guidelines regarding the code break trial. So KRAS also has to be included in the panel for non-small cell lung cancer.
Yes, okay, thank you. Dr. Kripa, will you do in all subset of patients, or you will do in a limited subset of patients?
I think clearly the classical teaching has been that we do it in never smokers, patients who have adenocarcinoma, mixed histology or an adenosquamous histology, or if the tissue is inadequate, where the tissue specimen is probably too small for us, then also we would actually like to get it done. For example, a female, never smoker, but even a squamous histology, in that case, I would like to look at doing a molecular testing even in that subset of patients. So I think that's in practice routinely the subset of patients that we routinely get molecular testing done for.
What about squamous histology?
Exactly, like I said, if at all somebody with a squamous histology is an definitely look at doing histologies as well. Even though the incidence might be much lesser, but nevertheless, if you're able to pick it up, then it does have an impact as far as your therapeutic decision making is concerned. So I would look at it like that. For example, even if you do, like we talk about the incidence of ROS1, and even like Aditya pointed out, NTRK, we know the incidence is only likely to be less than 1%. But nevertheless, we have a target which can be druggable, which is druggable. So, and for that reason, I believe that even in squamous histologies, it's worthwhile, especially if you have other markers that are going your way, then definitely I would look at doing it even in the squamous histologies as well.
Yeah, okay. Yes, fine. I think it is a broad range. Almost all patients except a few do not come, and if logistics are in place, yes, molecular study is the way to go forward. And that brings us to the discussion on today's topic, special situations beyond chemotherapy. Again, coming from Kripa, we will start. What do you think about this? What are the situations where we can treat, or special situations when chemo may not be your first or thought as soon as you see the patient?
So I think, for example, if you have somebody with a driver mutation, then we'll always look at targeting the driver mutation, which is especially if it's druggable as well. If you have a target and if you can actually identify that target and then use drugs against the target, I think that's the beauty of precision medicine, where we actually look at tailoring treatment according to that individual, who's sitting right across the table to you. So I'm a firm believer in that, and I believe that precision medicine is really the way forward, which is why I believe that molecular testing should be done, and that will probably help guide us in our treatment decision making as well.
Okay, so that is the precision, and as per the targetable mutations which you get in the pathology tissue will bind us to it. Yes, Dr. Aditya Murali. Okay, any special situation when you have a targeted mutation but still you don't want to give the drug?
By and large, if you look at the approvals, be it the exon 20 mutation, as Nagendra spoke previously, the approval is only for the second line. Although there might be some data in the first line as well, the approval for exon 20 is still only the second line. Same with HER2 as well. Even if you pick up a HER2 mutation, TDXD is still going to be, Destiny Lung 101 is still going to be a second line. It's not going to be a first line setting. Same with sotorasib. Sotorasib is still going to be a second line rather than a first line setting. So just because we have druggable mutations, at least in day-to-day clinical practice, I do go by the guideline, ma'am.
Yeah, by the guideline. Okay, if there is a druggable mutation and if you have an approval at first line, yes, you use that. Otherwise, what the three situations that you have told, we use it in that a second line. Now, if you have a BRAF mutation where the BRAF is not the V600, okay, what would you have done in those particular patients? Yes, Dr. Raghav. Dr. Raghav Kesari?
Yes, ma'am. Ma'am,
Yeah.
the approval for dabrafenib and trametinib is with BRAF V600E mutation. Now, if
Yes.
that is not there, then I think the uh, protocol would be to go ahead with chemotherapy only instead of looking for any.
Yeah, better to give chemo if you don't have the proper mutations out there. Okay, yes, Dr. Ravindran. Now, see, some of the drugs are like quite expensive. See, only the EGFR, we have geftinib, alatinib, which is available as generic. Most even all the ALK inhibitors. Okay, talk about all the other even immunotherapy. So, when there is a logistics, what would you do? But you have a targetable mutation and you don't have generic.
Being a radiation oncologist, I would have passed over this question to the medical oncologist so they can answer it better.
No, and also I put a slides, doctor. Radiotherapy slide is up. Okay, what is the role of radiation?
In this patient who has got pleural effusion, absolutely no role.
No. This is the tumor now. I've shown. Can you see the PET CT? That's a tumor over the metastatic disease are now localized over here. So is there any role of local radiation? Patient is having pain because this tumor is eroding into the posterior chest wall.
No, I need to know the molecular status of the disease, whether what chemotherapy was given earlier, how many cycles of chemotherapy were given, what was the previous volumes, and what is the present volume. Depending on this, I would like to shift the patient into categorization of whether the patient requires palliative treatment or patient can go for a long course treatment. Because depending on the nature of response, we are going to decide on further course of action.
Yeah, even in
thinking this to be a palliative case, even then, since the thorax is being eroded, possibly I might go for an SBRT so that I can save most of his lung and give a good quality of his life. That would be a better option.
Palliative intent. Okay, palliative intent radiation, because due to logistics, we may have a case with a mutation, but we are unable to give the drug. There we restrict ourselves to the use of chemotherapy, and we use in those cases. Okay. Okay. Now coming to the as we already discussed the role of the okay, where we look into whether the mutations are there and then we go for the further treatment. Now, again, coming back to Dr. Kripa, in your practice, I'm sure if you have somebody who cannot afford ALK, all of the ALK inhibitors are also very expensive. What do you do in the positive?
So I think, ma'am, if you ask me in practice, we would look at using, rather than give the patient no ALK inhibitors, we would look at getting the drug on the gray market, or which is through the Bangladeshi molecules or the other molecules that we have access to, because that's something which we end up having to do, number one. Or and that's probably what I would do in practice if somebody's got a targetable mutation which is druggable in the first line as well, and rather than actually deny them a drug. And we have various other patient assistance programs, like for example the BPL scheme, below poverty line scheme, which made crizotinib actually available from Pfizer in the first line for everyone. So if there's a chance that I could not put the patient on that sort of a scheme, then I think the next best option would be to actually look at these other molecules. I know I'm opening up a Pandora's box here, but still, nevertheless, rather than deny the patient or end up giving the patient nothing, I would look at actually putting them on any of these Bangladeshi molecules.
Yeah, but see, so many of them have the government card. What we face the difficulty that they don't want to buy from outside because and this gets not covered. Okay, these are different things to be discussed, and we are really stuck at that point of time, because whenever you write a prescription outside, patient has to shell his money. But if they have a government insurance, they don't need to pay. So there may be situations we have given chemo in spite of that, because patient doesn't want to spend, and that drug is not in the approval papers. Now coming to Dr. Aditya Murali, quickly, in your case of a non-small cell lung cancer, when you have these, which are the patients you are going to really choose out for immunotherapy? Now immunotherapy has moved in first line.
So any patient with a non-small cell lung cancer without a druggable mutation, irrespective of the PD-L1 score, the recommendation and my own clinical practice is to offer them immunotherapy along with the chemotherapy in first line. Only if patient has a PD-L1 of more than 50% and maybe a low burden disease, very rarely I offer single agent immuno.
Okay, but that means you want to say irrespective of the PD-L1.
Irrespective of PD-L1, yes. That is the recommendation, and that is my clinical practice as well, Dr. Anita.
Yes. What about Raghav? Do you really practice this? Dr. Raghav?
Yes, ma'am. If the patient is now, if affordability again is not the issue, then as per the guidelines, even without, like, even when the PDL1 is less than 1%, there is data for immunotherapy. Now, if that is not the issue, then we go ahead, and especially for all the panel patients where the treatment is covered by the government, there the recommendation is always to start first line immunotherapy with a chemotherapy backbone, of course.
Of course. And if you have to choose the immunotherapy, what drug would you use here?
Mostly the regimen that we use is because it's mostly 3 weekly, so pembrolizumab, carboplatin, or pemetrexed. That is what we usually start with.
Pembrolizumab. Any other choice, Dr. Kripa?
So I think probably, ma'am, I would, in the subset of PDL1 less than 1%, I would look at using an IO plus chemo based on the Checkmate 9 LA. Nivo EP plus chemo is what I would look at doing if somebody's got less expression. More than 1%, I'm happy with just a single agent IO plus chemo. And more than 50%, like Aditya also rightly pointed out, either a single agent IO or combine it with chemotherapy to get better responses. I think that's how I would look at doing.
And if IO choice, you said double is nivolumab, ipilimumab. How do you place atezolizumab? Also has approval in lung cancer, okay, in the first line, as well as. So which is the drug that you're going to use?
So if you're talking about the ABCP regimen, the 4-drug regimen, the so-called 4-drug regimen ABCP, is patients who have a high, let's say, for example, with liver mets or very large volume of disease where I'm looking at a very rapid response, then probably is where I would be tempted towards using the 4-drug regimen. Else, I would just stick to the algorithm that I just spoke about.
4-drug regimens, okay. Now, coming to Dr. Ravindra, so just quickly in relation to radiation, initially we had heard a lot of papers and we discussed about abscopal effect with radiation and immunotherapy. But then the recent researchers and papers coming out is not supporting that same concept. Your thought process, doctor?
Yeah, because I was involved with a study with Pacific 2, where we tried durvalumab for squamous cell carcinoma more than stage 3, concurrently with radiation. The response rate was not that great. So for that reason, I think possibly giving radiation along with concurrent chemotherapy with cisplatin or with paclitaxel or carboplatin doublet would be a preferable choice compared to combining with immunotherapy until unless we do not have a driver mutation.
Okay, so that immunotherapy effect, I think over a period of time, I think researchers tells it might not be that a viable option to be used for concurrent along with radiation. Okay,
yeah,
now
definitely.
Yeah, coming to Dr. Raghava Kesari, another thing, just coming to this future direction, how do you go about residual disease by circulating tumor cells and DNA to find out high risk population, provided a subset of your patient does now as a PET negative report?
Ma'am, when the patient has a PET negative report, clinically does not have any features of the disease, like there is no cancer cachexia or any other feature, and the pet is clean. As of now, we are not doing this. Like, but in future, yes, definitely there might be a role of this. Considering in the biopsy inaccessible sites, we are now using ctDNA for like where we cannot do biopsy. We are using ctDNA. This might have a role in the future, but as of now, though, we are going first by the clinical thing, the clinical features of the patient, and if that is, then or in the assessment PET CT, I think.
Yeah, because with immunotherapy, I have a couple of patients, not only with lung cancer, there's complete disappearance of the tumor. Okay, whether you call single agent pembrolizumab, nivolumab, so I ask those questions because with chemotherapy you may not get a complete PET negative, but with these newer drugs you might get, and to how to proceed. So do you stop at that point of time, Aditya Murali?
Dr. Anita, to be honest with you, CTCs, none of the Indian labs doing CTCs are validated, and taking any clinical decision on the basis of this report, these reports are premature in my very personal view. Irrespective of whether the PET is positive or negative, any patient with a stage 4 non-small cell lung cancer is unlikely to be ever cured. So we go by the trial data that we have. If somebody has been on immunotherapy for 36 months, that's when we stop. Otherwise, we continue treatment.
Yeah, you go by that. I agree with most of the circulating DNA. Its detection, I think none of the validated of the liquid biopsies for the picking up of the residual disease. Because why I brought this question, with immunotherapy, many of the patients do have scans negative in all of the malignancies. So how do we do? Whether we stop or we give up to 3 cycles or we continue till progression. Okay, coming back to Kripa, quick last question. I want to finish on time, 7:20. Dr. Kripa, any additional points on these special situations beyond chemotherapy?
I think to sum it up, I think you rightly pointed out and Nagendra also spoke about right now, I think for exon 20 insertions and KRAS and HER2 in the first line, even though they are druggable mutations, you cannot end up using the targeted agents right now because they're not approved for use in the first line setting. So you will have to go ahead with the combination of platinum-based chemo plus IO in the first line setting, and then look at targeting these druggable mutations in the second line setting. And as far as CTCs are concerned, I think we do have a DCGI approved CTC from Onco Discover, which is actually being marketed in India right now. Right now, like Aditya rightly pointed out, it's not yet approved for use, but then it's already DCGI has got it, and it's got from Onco Discover. The CTCs are available. I think the adjuvant setting probably is where we have a role for these monitoring disease as well in the recurrent setting. So with that, I would hand it over back to you, ma'am.
Yes, thank you. I think we have a good, difficultly we discussed all the special situations beyond the chemotherapy, where the chemotherapy may not be the choice, but when you have a mutation, and it is very essential that we go and do the mutation analysis, okay, depending upon the logistics, whatever panel is possible to get us a druggable mutation, so that this has shown over a period of time, it has improved survival, progression-free survival in these type of tumors, which has very poor outlook, and cooperation of these drugs have definitely helped them to bring a better survival. And that's why we keep on discussing lung cancers, because there are situations when we also get double mutations, 2 different mutations, and we get PDL positive tumors with the mutation. Yes, I leave it. We can discuss at a later date. Thanks to the organizers, thanks to Oncology Review, Dr. Sumant, and Mice Ideas for bringing all of us together. I think again we are going back to, with the COVID, might be to the webinars, Priyanshi. So we would like to see you more often now.
Yes, ma'am. Yes,
Thanks.
yes. Thank you so much, Dr. Anita, for moderating such a great panel, and I thank all the panelists for supporting this panel discussion. Now, moving ahead with our third session, which is on hematology. And for this, I would like to call Dr. Suman Gupta to invite our chairperson for the session. Over to you, sir.
Thank you. And thank you everyone for such a lively scientific sessions. So it's a pleasure that this is a ISO sponsored event, and I have Dr. Bilimagga sir with us, who is the president of ISO. So before we start the next section and invite the chairpersons, I'd like to have Dr. Bilimagga sir to give us a few words of wisdom and the importance of ISO in our day-to-day life as clinicians. Sir, can I have you for 2 minutes?
Yeah, sure, Saman. No, thank you so much. Can you hear me now?
Yes, sir. Audible, sir.
Okay. Yeah. Good evening, the participants and faculty. It's so nice to hear. And on a Friday evening, when it's a holidays season has started, and people are sitting here to listen to the oncology and a review. And in fact, ISO is committed to the CME programs. And of course, webinar is one section that we are doing very regularly. And thanks to Suman and the group, and assisted by my ideas. Today, we have the third session, that's on hematology, and that will be chaired by Dr. Pinter is there? Dr. Pinter? Is it there?
So he was having problems with logging in. So he was trying to log in again and again. So sir, we can start with the session and we can have him.
Yeah, sure. We'll do that. And he can join us, even at a later time.
Yes.
What about Dr. Patel?
So Dr. Farhan, the first speaker, is ready, sir.
Okay, fine. Yes. Farhan, I know actually we second people, second speaker, but we have preponed his talk because the first speaker is not yet reached, and his talk is going to be on CLL and where are we, and that's very important to know where are we. That's very important, Farhan. Please go ahead, and we are very keen to hear you.
Dr. Farhan, can you hear us?
Farhan is not answering, but his slides have come.
Yes, sir. Dr. Sir, give me a minute. I'll just check.
Okay.
गिर जाएगा, अरे टुट्टू हो जाएगा, ऊपर नीचे मैंने देखा नहीं तो
Actually, and no, yeah.
So can we present your slide from our side?
Yes.
Yes, okay. Yes, sir, you can start.
Okay, so sorry for the delay. As I was traveling down from Mathura and got stuck in Bharat Jodo Yatra. I think I can finish on time now. So the topic given to me is CLL in 2022. Where are we? So next slide.
Can I have a next slide? So coming first to the classification, WHO 2016. So nothing much changes are there in the CLL classification since 2008 International Working Group classification. So the only introduction was the monoclonal B-cell lymphocytosis, which is considered to be a precursor of CLL, and we have an absolute lymphocyte count of less than 5,000, and there are the immunophenotype favors a monoclonal. This favors a CLL immunophenotype. So importance of CLL MBL is that there is a progression of 1 to 2% per year, and virtually all case precedes CLL precedes with the MBL. So this was the only inclusion in the 2016 classification. Next slide. So coming to the epidemiology, I think it's same. It's the most common in Western population, but less frequent in Asian population. And it's a disease of elderly with a median survival of nearly 7 years, male affected more. And the most common deaths are from the infections, bone marrow failure, and the Richter's transformation. Next slide. So this is the important one. So there's the data from the India where it was, I think, performed at PGI Chandigarh. So what they found again that as not as common in the Western population, it's less common in India, the least common one in leukemia, and the incidence lower among Asians and the younger age of presentation, as with all the malignancy we see in India, aggressive course in the short time of treatment. Next. So again, one more interesting point which I want to mention from this study is the upfront treatment use is around 30% was the bendamustine and rituximab. So I think everyone will agree with this because the chemoimmunotherapy most commonly used in our country, as apart from what the data says, is the BR regimen, and it is what we see in this from the study also. Next slide. So coming to the prognostic and predictive factors in CLL. So as the time passes on, I think everyone will agree, and the data also show the same. The most important predictive and prognostic factor in CLL now is the cytogenetic abnormality, especially the deletion 17p and TP53 mutation, and the IGHV mutational status. So this is the reason which which led to the introduction of the new prognostic index. Next slide is the CLL IPI. So the importance of this, I think, can I have the next slide? So the importance of this CLL IPI is the apart from the age and the clinical staging, which is the Binet and the Rise stage. So more weightage and importance was given to the cytogenetic abnormalities and the IGHV mutational status. So I think how to clinically apply this, I think still people are mostly using the Binet and Dry, but now people are started using because almost everyone started using all apart from the data what we got in the CLL for Indian data, only 50% got the fish, but I think in our practice now more than 80% patients, I think the fish and the IGHV mutational status is available. Next slide. So coming to the next, I think most important part of this talk is the progress in the treatment of the CLL. So what we also used in the very early days, and we're still using this alkylating agent, then came the purine analogs, then the combination chemotherapies, and then came the chemoimmunotherapy. I think which became the new standard of CLL and remained the same and is still being used. But now the paradigm has completely changed with the novel and the targeted agents coming. So we are talking more of the limited duration therapies with more MRD negativity improvement, not only in the PFS, now in the OS also. Next slide, please. So what are the available current therapies in CLL? So chemoimmunotherapy, which everyone is the conventional limited duration therapy. And apart from this, now with the upfront, we have the option of BTK inhibitors with or without CD20 anti-CD20, which is a targeted and continuous therapy. We have PI3K inhibitors with and without anti-CD20, a target continuous therapy, and the BCL2 inhibitor with anti-CD20 monoclonal antibody, and it's a targeted and limited duration therapy. Next slide. So now talking about the frontline therapy options in CLL. So if you see down the order, I've arranged in the order which I think most of us or the using or the data what is saying. So with the BTK inhibitors, with or without obinutuzumab, acalabrutinib, venetoclax, Ibru plus combination targeted therapies, and now next is the FCR and the other chemoimmunotherapy. So what data says is we now moving away from the chemoimmunotherapy, and most of the frontline therapy options is the target are the targeted therapies now. Next slide. So coming to the relapse setting treatment, so eventually everyone relapse in CLL. The treatment options at relapse are driven by the quality and duration of previous response, age and performance status, development of deletion 17p, which we do every time the patient relapses and we are going to start the next therapy. In absence of a prolonged frontline response, patient has switched to alternate treatment, but the options almost remain the same, other except the PI3K inhibitors, which we are approved for the relapse settings. Next slide. So I think this is an important thing to discuss now. We are done with the chemotherapy. If we see the data, yes, almost. But it's still a young portion of the population can be considered for chemoimmunotherapy if they have a IGHV mutated status. But the chemoimmunotherapy, what we see the benefit is with the FCR, not BR. But as we know that in our setting, most of us will agree that FCR has got a high infection rates, and we are less confident in using the FCR. Most of us still using the BR in our population. Next slide. I think this is being proven with the long-term data available now with the studies. So this is the E1912 trial with more than 5 years data. So you can see that there is a significant benefit in the ibrutinib rituximab group versus FCR. And not only the next slide, if you see the subset analysis with the IGHV mutational status in both the ibrutinib rituximab and next slide and the FCR group. So in IGHV unmuted, definitely there is no role for the FCR now. But in the patient with IGHV mutated status, if you see the initial data, the lines were not separating. But now, if you see the long-term data, the lines are not separating. So means there is even in the IGHV mutated status, there is benefit, PFS benefit in ibrutinib rituximab group. So I think with this, at a point in any group of the patient, the best available treatment has become the targeted therapy now. Next slide. So this is again a long-term data we now got up to the 8 years. So the CLL, which is a disease where we always talk about the PFS, now we can see we are getting the data, long-term data and talk about the overall survival benefit also, which we can see in this long-term data of this RESONATE-2 trial. Next slide, please. So coming to the potential adverse events with the ibrutinib, I think which one important point is if you see the toxicity with ibrutinib leads to discontinuation up to 20% in trial, but I think real world experience it's around 30 to 40%. So it's not that easy to give a ibrutinib in a long run. Giving it like a continuous therapy, we have a good number of discontinuation rates, and the reason being most commonly is the side effects, which we most important are the arrhythmias, hypertension, bleeding, and of course the high atypical infections, which has led most of us to use the, I think Septon, many have started using with the ibrutinib now. Next slide, please. So this is the next coming to the acalabrutinib. This is the ELEVATE-TN trial in the treatment naive patient. They compared acalabrutinib with or without obinutuzumab with chlorambucil and obinutuzumab. So if you see, there is clear, it's a PFS advantage in both the groups, acalabrutinib alone or with or without the combination with obinutuzumab. But important thing, if you see, the acalabrutinib does better in combination with obinutuzumab, contrary to ibrutinib, where there was no significant difference between the ibrutinib alone or with the anti-CD20 agent. Next slide. So it's a next trial of the acalabrutinib where they compare with the ibrutinib, Elevate RR. So it was actually a non-inferiority trial where they found that it's non-inferior to ibrutinib. But more than this, next slide, we talk more about the side effect profile of acalabrutinib versus the ibrutinib. Next slide, please. So if you see the most common adverse events, actually the added advantage which is being considered about the acalabrutinib is some selective side effect profile, which found to be a fair better, like hypertension is significantly less in acalabrutinib group and the atrial fibrillation rates. But still, if you see the grade 3 or more, I think there is not much difference between the two. So even the acalabrutinib has got an increased risk of atrial fibrillation. Next slide. So coming to this, all combining all the BTK inhibitors. So if you see the BTK inhibitors with or without anti-CD20 antibody is more effective than chemoimmunotherapy in the treatment of CLL, which is being proven now with the long-term data. So although it is difficult yet to prove it for subset of patients which who are IGHV mutated disease, so we need further data to look into this, because FCR, if you see, is a very good therapy for the young patient who can tolerate it, because we get a good number of cure rates with this. Next, anti-CD20 antibodies may be better combined, as we saw with the acalabrutinib than with ibrutinib. Acalabrutinib is as effective as ibrutinib and may have a different side effect profile with for some key toxicities. Zanubrutinib, although not mentioned here, has shown similar efficacy profile to acalabrutinib, but potentially less atrial fibrillation. So next slide, please. So I think there are ongoing trials for zanubrutinib, which I will be taking in the next slides. So coming to the next targeted agent, which is a venetoclax, so serial 14 trial, where they combine with obinutuzumab with and compare with the chlorambucil group. So it showed a significant overall PFS survival, PFS benefit. Next slide. Next slide, please. So coming to what does this this venetoclax trials, they have shown that at 4 years of PFS for venetoclax with obinutuzumab is similar to what has been reported for ibrutinib and acalabrutinib. But the patient I've missed the previous slide. This PFS. That if we see the subset analysis, so the TP53 altered and IGHV mutated disease may have shorter PFS with venetoclax and obinutuzumab. So this is one concern with venetoclax. I think this concern, this will be more clear with the ongoing trials where there is direct comparison with the ibrutinib with along with the venetoclax. And again, the long-term studies will be critical. That I already said with the coming up study I will be discussing in next of my slides. Next slide. The next slide. So coming to next slide, coming to combined targeted agents, I think which is being talked most now. So what is the rationale of combining the two targeted agents, which are ibrutinib with venetoclax? So they have a non-overlapping mechanism of action. They have non-overlapping toxicity profile, which is very different in both, act on serial cells in different compartments. So that's the reason for the synergy in preclinical studies, and which can potentially deepen the response. Not only this, the reduced TLS risk by ibrutinib leading treatment prior to the venetoclax. So we give a 3 cycles of ibrutinib before we start the venetoclax. Next slide, please. So this is the Captivate trial. So where they have looked into the fixed duration cohort of first line ibrutinib with venetoclax for the treatment naive patient. So this it's very these data are very good. And not only this, if you the next slide, so if you see the PFS very and still this they are taking coming up, we need long-term data in this trial. Next slide. So if you see the same this adverse event, this profile, so I think this is both are different. So these venetoclax causes more of the hematological toxicities, and there are grade 3-4 neutropenias and thrombocytopenias. And with the ibrutinib, we have a good number of cases with hypertension, atrial fibrillation, and the bleeding incidence. So this, I think, with the differing side effect profile and added and the different mechanism of action, I think combination works could be handy in this. And I think further trials where we are comparing the company combined targeted therapy with the single agent, so that they will, I think, clarify it further. Next slide. So it's again a GLOW trial where they compared this fixed duration combination with the chlorambucil and obinutuzumab, and you can see this advantage PFS in the PFS in the both the groups, and as expected. Next slide. So again, what does the trials which tells us that combining a BTK inhibitor with the BCL2 inhibitor regimens produce impressive response and MRD undetectable rates. So this is one more important point. The thing I think I will be mentioning later on, that these trials, they look for the MRD both in the bone marrow and the peripheral blood, and it's quite impressive. And the short-term PFS is outstanding. Although the long-term data, I think we all are waiting for this. Next slide. So these are the additional BTK inhibitors, Vantoclax with or without anti-CD20 antibodies. So if you see, these trials are ongoing with all the three BTK inhibitors with Vantoclax with along with the anti-CD20. And I think all these, there's a good number of trials going on, and I think we'll be waiting for the results. But most important would be, I think, the next trial which I will be discussing. Next slide. This is serial 17 trial, and this is the compare. This we are comparing the ibrutinib with Vanto plus obinutuzumab with dual targeted agents. So this is, I think, the most awaited one, and will give the answer where we should start with a dual targeted agent or a single agent is good enough. I think this is one of the most awaited one. Next slide. So at 4 year, ibrutinib, acalabrutinib, and Vantoclax plus obinutuzumab appear relatively equivalent in terms of survival. So this is the early results. This is the like interim analysis. So there might be a difference for patient with TP53 altered and IGHE unmutated CLL. So I think this is what we discussed in the high risk patient. The Vantoclax is seen to be inferior to the BTK inhibitors, and if it is so, then I think the use this would be like this would be a very important thing, which is important hypothesis, which still not, I'll say hypothesis because till the results are coming up. So, but the initial is what the results which are seeing the interim analysis, they are in favor that venetoclax does that well in the high risk patient as the BTK inhibitors. But anyhow, we need the Vantoclax, we need the long term data, and I think will be available soon. Next slide. So coming to the novel approaches in frontline serial therapy. So again, the novel, if you talk about see the novel approach, it's, I think it's the most important one is the combining a dual targeted agent BTK inhibitor with BCL2 inhibitors, and other approaches with the MRD directed approaches with the once the venetoclax is there. So we are talking more about the MRD negativity. And not only this, we have a novel therapeutic agent I'll be discussing next. Next slide. So next slide. So we have some novel BTK inhibitors. So first is the zanubrutinib. Next slide. So we have next slide, please. So we have now data available where we compare the zanubrutinib with the ibrutinib, and in the treatment in a patient with relapse refractory CLL. And if you see next slide. So the this Alpine study, they have shown that zanubrutinib significantly improved the overall response rate versus ibrutinib, and not only this. Next slide. I think next slide. So if you see, I think the further data what is available is that this zanubrutinib has shown a PFS advantage over ibrutinib. And if you see the side effect profile, zanubrutinib is less toxic, even with less toxic in some toxicities, especially cardiac, compared to acalabrutinib. Next slide, please. So next, coming to the pertobrutinib, so the one of the important point which I would like to mention here is, especially there are certain scenarios with the more of the we are using more ibrutinib, so we are coming up with a more resistance against the ibrutinib, and the patients who already exposed to venetoclax or they are intolerant and they are, if they progress on ibrutinib, and this group of patients is very difficult to treat, especially high risk patients which have a high risk cytogenetic abnormalities. So in those cases, we have we have used this drug pertobrutinib, and what we see that these are called a non-covalent BTK inhibitors, and this ibrutinib and other groups, they are called the covalent BTK inhibitors. So reason being, the site of action is different in the both. So the resistance, the mechanism of resistance is basically mutations in the binding site of the BTK. So since they are binding at a different site, so they are effective in the patients who are resistant or relapses over the ibrutinib or acalabrutinib. Next slide. So coming to the other novel PI3K inhibitors with combinations with this umbralisib and the ibrutinib, in combination is typically called U2. Next slide. So it has, this is a unique structure and activity profile distinct from other PI3K delta inhibitors, but the safety profile is better with the less hepatic toxicity and colitis and the high selectivity to PI3K delta. Next slide. So this is a Unity serial trial where these both the combination they have compared with the obinutuzumab with chlorambucil. Next slide. And there is another trial going on, which is the Ultra V trial, where they compare the rituximab, umbralisib, and venetoclax versus rituximab and umbralisib in the patients. This they have taken the patients who are treatment naive. So I think I will not be discussing much about this because we have lots many molecules which are available and we have to use. And I think the time is far ahead for these molecules. I think. Next slide. So next, coming to the cellular immunotherapy, we have CD19 targeted CAR T cell therapy. I think this is again the group with the patients who already exposed to or intolerant to venetoclax and relapsing on the ibrutinib with high risk cytogenetic abnormality. I think this is the group where we are looking for the CAR T cell therapy. Next slide. So I think I will not discuss much because Dr. Pishan will be taking a session on the CAR T cell therapy. So this is how we collect the autologous CAR T cell, give a conditioning, and then gently engineer them and reinfuse. I think this will be taken by Dr. Pishan. Next slide. So this is Transcend CLL-004 trial, where this and the CD19 directed CAR T cell therapy, they have used both phase 1 and 2 trial, where they use as a monotherapy or with the combination with the ibrutinib, and in very highly refractory patients. Next slide. So I think this is the early data of this Transcend CLL study, but I am not discussing much about the CAR T cell. Next slide. Okay, next concept is the MRD directed approach. So with the use of the venetoclax and the benefits we are seeing with the advantages treatment with the venetoclax, now more of the MRD directed approach is being talked about. Next slide. So again, the same next slide, same slide which this study. I think previous slide, please. So in which the venetoclax and ibrutinib combination was trials fixed dose. So it was look for they look for the MRD and other trials, glow trials and what serial 17. So now now they are using coming up with MRD directed approaches both in the bone marrow and the peripheral blood. I think it's still not very clear which should be used. Next slide. So after discussing all the available options, so what would be the future therapy landscape for CLL? So if this, I think, would be a lot of things we need to decide based on the patient biology, disease biology, patient differences, safety, toxicity profile. So we have options with the continuous versus fixed duration therapy. So we have a chemoimmunotherapy, which is a fixed duration therapy, but as we see, it's very small subgroup gets benefited with this FCR regimen, and that too a toxic regimen, very difficult to tolerate in our population. I'm not sure the results are equivalent in our population as the BR, and other is the continuous therapy with the BTK inhibitors, and now with the BTK inhibitors combined with PCL2 inhibitors as a fixed duration therapy. I think this is the most excited. Everyone is excited and want to see the long-term data where we compare with the single targeted agent with the combination of these targeted agents. Next slide. So now concluding my talk. So first thing is the future of the frontline CLL is bright with the upcoming newer molecules and less side with the we are coming up with a less side effect with the better side effect profiles. The use of chemoimmunotherapy is steadily declining, as we all will accept this. But given the better side effect profiles and improved survival with the novel agents, but I think this is still not same in our scenario. We are still using a lot of chemoimmunotherapy, as we saw in Indian data. We are used in around 30-40 patients on the upfront. For most of almost all patients, target therapies are preferred to chemoimmunotherapy. Now that trials long-term data is available, where we can see yes, in even all the subgroup, they fare better than the chemoimmunotherapy. The choice of targeted therapies is determined by patient preference, disease biology, finances, and pros and cons with each therapy. So now, last is the ongoing and future studies will help, especially the CLL-17 study, where we will give the answer at a single targeted agent, or we should use single targeted agent, or as a dual targeted agents should be used. I think with this, I would finish my talk.
Thank you, Farhan. And in fact, you have covered extensively, regarding the CLL, and starting from the days of alkylating agent and to the to the today's and how the novel therapies have been instituted. And in fact, it is a typical example how the science is developing in all the field, and particularly so in CLL, and to boast of how a cancer can be made as a chronic disease, and a successful story of a CLL stands out very diligently. Thank you very much. With this, I hand over to the next, next our chairperson, Dr. Patel, and go ahead inviting the next speaker, please.
First, sir, I would like to request Dr. J.M. Kungar, sir, to ask the question. One question is there in chat box.
Oh, yes, yes, yes. There was one, correct, correct. There's one question. Yeah, I just saw that. Yeah. Can you see that, Farhan?
Yes.
In the chat, yeah. Can you answer that?
I could not see the question.
Farhan, I'll read out the question.
I will read it out for you. And may I know and where anything other than TP53 status and which is and which is high risk other than TP53? Is there any?
So we the high risk feature if we see most commonly is most important is the 17p deletion or TP53 mutation, and apart from this IGHV mutational status. I think these are the two most important high risk features which we usually look in the patient managing with the CLL.
Okay. Okay. All right.
Now I would like to invite Dr. J.M. Kungar to introduce our next speaker. Sir, over to you.
Good evening, everybody. Now it's my proud privilege to introduce Dr. Prashant Mehta. Our next speaker is Dr. Prashant Mehta. Dr. Prashant Mehta is a senior consultant in Amrita Hospital, Faridabad, in the Department of Medical Oncology, Department of Hematology, and Bone Marrow Transplantation. Dr. Prashant Mehta is a very good singer also. I've listened to his songs also, and he's very good speaker also. This is well-known entity in the field of hematology.
Thank you so much. Thank you so much for that kind introduction, sir. And
which is you going to start with,
yeah.
with singing or talk?
I think today we will start with the talk, and maybe next time we can have some music also.
Yeah.
Yes.
And so the talk is from Prashant's studio, where he sings.
Yes, it is actually. I hope you can see my slides.
Yes, it's visible.
It's visible. Okay. Okay, so finally we have seen CAR T cells. The cart has traveled to India. Although they have been very slow, like a bullock cart, but they will be faster and they will very soon travel to our city also soon. With the efforts of so many doctors here in our city as well, so many great oncologists here, and even Sumant there and Farah and everybody's there. So I'm sure very soon CAR T cell will become a reality in Faridabad and our nearby places as well. So I'll just proceed with my session. So so Dr. Carl June actually was the PI of the study, which happened in University of Pennsylvania, and there was a patient one, the famous patient one, and her name was a little girl named Emily Whitehead, and she was suffering from ALL, and she was relapsed refractory, nothing was working, and thereafter she was enrolled onto this study of this novel therapy, so called the living drug. And these living drugs, these T lymphocytes, actually they were actually genetically modified to have certain different kind of receptors which were genetically engineered to recognize the target, that is CD19, on the leukemic cells, and they bound there, and they uh, expanded, and they killed these cells, and they persisted, and they were actually, that's why they were deemed as a living drug. And they showed that they could persist for very long periods of time, sometimes years. And they were actually created from the patient's own blood cells. These were autologous in origin, and this is what the CAR T is, the CAR T cell therapy. And this is how it all started with this girl, and this girl is still alive and doing very well in remission. And it's been 10 years now. She was treated in 2012, I believe, in University of Pennsylvania, and by Dr. Carl June's group. So what is the mechanism of action? As I just elucidated, there's the T lymphocytes. They have a T cell receptor on their surface, and what happens is, in this situation, we use a viral vector which inserts DNA sequence inside that T cell, which is something different from what they usually would have, and the receptor on the cell surface is also becomes something different than what they usually have. And what that receptor is, we'll also discuss that. And these T cells express this CAR, the modified receptor, the chimeric antigen receptor, and these receptors actually can be designed to target anything, virtually anything. And in this situation, these are lineage specific antigens called CD19, and this is where these receptors are directed to bind in situations of leukemia, B cell leukemia, and B cell lymphoma. And that's what happens. And they're able to recognize these targets, and they're able to cause apoptosis of these tumor cells. And how are they synthesized? Uh, these are basically extracted with a simple leukapheresis from the patient's blood. It's a simple procedure, and these cells are then processed. They are sometimes shipped to a center where the engineering takes place, or sometimes locally when they are in a situation of institutional or academic cards, and they are re-engineered by viral insertion mutagenesis to express these CARs. And these modified T cells are expanded in culture and grown with interleukins in cell culture. And these cells are later shipped in sometimes in cryopreserved medium, liquid nitrogen, and then they are infused. Or in situation of academic cards, they are sent locally to the treatment center, and these are infused. Generally, the dose would be about 1 to 2 million or 2 million carts per kg of the patient's body weight. And this is what is the dose used, and it is generally preceded by a conditioning chemotherapy. And why that happens, we'll also have a look at that. These are some of the studies which have shown dramatic results in relapsed and refractory adult ALL. And you see the remission rates here, and the toxicity, that's mostly the CRS and the ICANS, or immune effector cell neurological syndrome, that's ICANS, neurotoxicity about 40-50%, and then the CRS ranging from anywhere between 20 and 90% as well. The vectors can be lentiviral, retroviral. They have very peculiar features, these vectors. And this is the signaling domain, the co-stimulation. We'll also discuss co-stimulation in my subsequent slides. And this is the patient profile. These are difficult set of patients. They're relapsed refractory, or they have undergone previous HSCT. And these have actually been able to achieve an MRD negative remission with this strategy, the CAR T cells. That's why it is so dramatic, and it's such a wonderful thing which has happened in science over the last few years. So this is some other pediatric studies, similar results. Eliana, a very popular study, 41BB cards. CD28 and 41BB are slightly different with regard to the T cell expansion. The CD28 causes more T cell expansion, and they are more prone to CRS as well. CD41BB somewhat less. They cause less of cytokine release and robust T cell expansion. But activity-wise, I won't say there is much difference based on the data. But yes, there is some biological difference between these co-stimulatory domains. What is the immunological basis? So we have B cells on one hand and T cells on the other hand, and these have receptors. T cells have T cell receptors, B cell have B cell receptors, the BCR, they recognize a single specific antigen, and they both have the property to expand through clonal selection. What is the difference between these receptors actually? BCR actually directly recognizes and binds to surface antigens, and this is basically nothing but an immunoglobulin entity on the surface of the B lymphocytes. That's what BCR is. TCR, on the other hand, it recognizes antigens only which are bound to MHC or HLA and presented by antigen presenting cells. B cells, on the one hand, they secrete antibodies. T cells don't secrete antibodies, they secrete cytokines. So that's the basic difference, and it's important that we know this before we venture further. So what are the various phases and types of T cells? We need to know all this: naive T cells, memory T cells, how the T cells get activated, what is the importance of co-stimulation, how memory T cells are formed. So we will just briefly touch upon all this. They are, the pre-T cells in the marrow, then thymus, there is maturation happening. Then we have the naive thymic emigrant T cell, which can be the CD4 positive, 8 positive. Then antigenic stimulation, it causes the maturation, and these are the effector and the memory T cells. Naive T cell activation actually requires not only the TCR and MHC restricted antigen presenting cells, but also co-stimulation, which is either CD28 or CD41BB in some cells. And these co-stimulatory domains actually are absolutely necessary for T cell activation and expansion. So without this, the T cell will not actually work and will not cause any change and any effect on the tumor cells as well. Activated T cells, the memory T cells, are basically a repository of antigen experienced T cells that actually keep accumulating over a lifetime, and they're able to respond faster and more effectively to antigens, and they persist even in the absence of antigen. And basically, this is how the vaccination also works. The central memory T cells reside in the secondary lymphoid tissue. They're capable of self-renewal, while effector memory T cells, they are not. The central memory T cells are important because this type of CAR T cells, the central memory T cells, if this clone is more in the CAR T cell product, the efficacy would be more. And this is what is the quality of the T cell. The quality of the T cell is what determines how good the efficacy of the CAR T cells is going to be. And these kind of cells in the CAR T product and expansion later in the body, in vivo expansion, it is what determines the responses as well. So what are the mechanisms by which tumors are able to avoid antigen immune recognition? These are some of the examples how they do it. They can be low immunogenicity or tumor treated self antigens. They in the absence of co-stimulation, they get tolerized, and there can be some checkpoints like PD-L1, PD-1, CTLA4. These can cause immune escapade, and sometimes tumor are in a privileged site. There are a lot of mucin around. They have a physical barrier, and the immune system is not able to penetrate. Sometimes there are Tregs which are causing resistance. Then there can be TGF beta like molecules which can induce resistance. So tumor environment can be hostile, especially in the case of solid tumors. That's why solid tumors have the microenvironment does not favor the efficacy of CAR T cells, and that's why the solid tumor studies are not as robust as the heme studies are. So why CAR T therapy? Because there is a effect on the tumor of the lymphocytes. How do we know that? Because we have transplanted and we have seen graft versus leukemia effect, graft versus lymphoma effect. It is there. When there is GVHD, there is better chances of survival and remissions. And when there's not, there can be relapses. DLIs also provide a rationale that T cell therapy works. And you can see here that CLL progression actually responds to DLI. Same with CML post-allo patients. They also respond to DLI very well. And the efficacy though in ALL for DLI is not as good. ALL relapses post-transplant are very difficult to manage, much more difficult than even the some of the other disorders. So that's why we know that we needed to harness the T cell in better ways and dissociate this GVHD from GVL. And what are the various strategies? So this is what the strategies can be. We can have transfer of polyclonal cells, which we do in HSCT. We can have bispecific T cell engagers like blinatumomab, a transfer of antigen-specific T cells like CAR T cells, and we can have other types of cells like CAR NK cells, or we can have other types of cellular therapies, dendritic cells. All this can be dendritic cell vaccines can be there, and all these are being trialed. Then there can be checkpoint blockers like CTLA4 inhibitors or PD1, PDL1 blockers, and various strategies are there. These products can either be autologous or they can be allogenic. Allogenic products are also now in late phase studies, and we're going to have some off-the-shelf allogenic CAR T cells very soon in the market probably. What is the design of CAR T cells? You see here, it is basically a combination of B cell receptor and T cell receptor. How is that so? So you see the B cell receptor is an immunoglobulin entity, and there is a heavy chain and light chain. At the front, you see the variable component is there. And this variable component, this gene, is basically a part of that sequence, the single chain fraction variable. They are connected here, and then there is a transmembrane domain, which is important for signal transduction here. And there is a T cell receptor component, which is the CD3 zeta. And here it is attached beneath the transmembrane domain. This is the structure of the CAR T cells, the earliest one which was synthesized. This is the first generation CAR T cells. By the way, all the commercial CAR T cells products right now are second generation. And they have, all of them, they have a co-stimulatory domain, which could be CD2841BB. So this is the structure. The anterior outside portion is the antigen binding domain, the SCFV or single chain fraction variable, and there is a hinge region with a co-stimulated domain like CD28 or 41BB. Then there is a CD3 zeta chain, the signaling domain, which is inside the cell. And this is what is the component of the T cell receptor. That's why this is a chimeric receptor, because it combines these two types of receptors and then a co-stimulatory domain. Evolution is first gen without the co-stim domain, without CD2841BB. Now we talk to OX40 also. It is a newer co-stim domain. And the third generation CAR T cells coming to those, they have not only one, but they have two co-stimulatory domains. So they are most robust in expansion and persistence. And this is the third generation CAR you can see here. And so this is the evolution of the CAR design. These are the various better innovations now. They can be dual chain CARs. They can be trucks which have another gene inserted for an interleukin, and they can be bispecific CARs who can have two targets, or they can have tri-specific CARs which can have three targets, and all this is possible now in better engineering. The methodologies used to be initially the viral insertional mutagenesis, but it can be done with CRISPR and newer techniques. You can edit the sequence and insert it. So what is a good tumor antigen? On the cell surface, it should be, because it should be external so that the CAR is able to bind it. It should be consistently expressed, not downregulated. It should be critical to the tumor cell, expressed on the malignant stem cell, because stem cell, if it is there, it can eradicate the minimal residual disease. It should not be expressed on normal cells. Most at present what we use is lineage specific, like CD19, because they can cause some off-target effects like B cell aplasia and some are lineage specific polymorphic, morphic, like kappa versus lambda chains. These can be there. And there is a very important antigen on the myeloma cells, the BCMA, the B cell maturation antigen. These are also lineage specific antigens. And now we talk of a new antigen on the myeloma cells, that is GCPR5D. That's the newer target for CAR T cells in myeloma. And it can actually work with post BCMA CAR T relapses and have durable rates of remission with that. The Indian initiatives, coming to how the cards have traveled to India now. So this is the IIT Mumbai and TMH initiative, and this is what the inception of the ImmunoAct was. And Dr. Gaurav Narula met Associate Professor Rahul Purwar in IIT Mumbai, and extremely wonderful people, and they have actually worked very hard. Because I remember in 2018 or 17, I think I started working on this, and at that time, just at that moment, the guidelines for GTPs, the gene therapy products, actually came about in India. And if you read that document, it has very stringent rules and regulations with synthesis and manufacture of gene therapy products. CAR T is actually a GTP, a gene therapy product, and they have rules which they have defined. There's a body in DCGI, the GTAC, which regulates all that, and they have been thoroughly following all the regulations, the preclinical studies, the animal studies, and then the phase 1 study. Now the phase 2 has started, and it is so great to see this happening. This is the group which has worked very hard. Dr. Naveen Khatri, one of my teachers and mentors there in the middle, and this is I think this is Professor Rahul Purwar there. And Dr. Narula is not there in this team, but I know many of these gentlemen, and Dr. Hasmukh I've met personally. He was a part of the phase 1 ALL, study, and they have done wonders. So they are all over the news. They are in KBC, and they should be, because they have done exemplary work. It's very difficult work they have taken up and they have completed. And this is actually a humanized card. All the commercial cards right now are humanized cards, and this is actually a H card, or a humanized card, or a fully humanized card. And the ones who commercially are not fully humanized. So they have less incidence of CRS, hardly any, in fact. And 3 out of 10 CRs were there, and ORR was about 50-60%, and they have done well in the first line, in the first study. And it's actually a population which was relapsed refractory, a very difficult population to treat, and the cells have actually worked, and they have published in ASH this data. This is the leukapheresis process they have used, and some protocols. And what are the factors which could affect? Just briefly, I'll touch upon that. If somebody has got some therapies like bendamustine before CAR T cell, the leukapheresis, they are bound to have some poorer quality of T cells. So earlier we preserve take the leukapheresis, it's better. And before giving drugs like bendamustine. These are some of the manufacturing facility. This is the GMP lab, and the GMP is, it's very strictly regulated, and they're very, fine nuances to it, which it's there in the document from the government of India. These are the viral vectors which are used. We talk of this insertional mutagenesis. What are the retroviral and lentiviral vectors? What are the differences? Important thing, as opposed to the retroviral vectors, the lentiviral vector transduction is not governed by cell division actually. So it allows more effective transduction of a wide range of cell types, including the non-cycling cells. So, but overall, if you talk of efficacy, I would not say would not be any different. This is the patient journey we have spoken about. Lymphodepletion is a very important part of treatment with CAR T cells, because they not only provide disease control and they eliminate the Tregs, but they also help in releasing the homeostatic cytokines, which cause T cell expansion, the CAR T cell expansion. This is driven by the conditioning therapy, which is drugs like fludarabine, cyclophosphamide. This is how it happens. You can see with and without the fludara and expansion is obviously much greater with these drugs. Other regimens are also in use, and fludarabine is short in the US, so they are also considering bendamustine probably now for, and probably clofarabine. I've seen those discussions happening on Twitter. So lymphodepletion, some practical considerations. A patient with low lymphocyte count may not be necessary to do a lymphodepletion. They or already lymphodeplete. The cells are given anywhere between the second day to sometimes 10 or 11 days after the conditioning chemotherapy. But it's better given in the initial 3 days or at max 7 days. If beyond 7 days, most people would repeat their conditioning chemotherapy. How are the indigenous CAR T cells different? They are fully human actually, and the co-stimulated domain. We can't have that disclosure yet. It's a patented, drug, and in fact, the facility, GMP facility in Mumbai, it is capable of catering to more than 30, 40 patients in a month, and that's different from Clinimax system, the Prodigy, which is the automated system. It can produce probably 2-3 products in a month, but this is able to do much more. It's a manual system. Other Indian initiative is the Siddharth Mukherjee and Dr. Sunil Bhatt's collaboration in Majumdar Shaw Cancer Center. They have also completed their phase 2 study. You can see this is the abstract in ASH now. Imagine study, 77% responses, complete responses. It's a very exciting drug. It's a Spanish vector actually. It's Spanish-Indian collaboration, and a lot of it is Spanish. And they've just used the automation with Clinimax and synthesized their CAR T cells. But has been used in India. So a lot of indigenous work has also gone through. What are the advantages of CAR T cell therapy? They're infused at a single point of time. The HLA independent antigen recognition. So there is a universal application. They're active in both CD4 and 8 T cells, rapid generation of tumor-specific T cells, minimal risk of GVHD, and capable of rapid proliferation and persistence on its own. They're powerful, specific, they have a memory, and they can be universal also. They can be allogenic also. Some of the commercial CAR T products, Tisaj and Leclucel, Kymriah. This is the one which Dr. Carl June used for Emily Whitehead. You can see the product, the specifications here. Some of the doses, the conditioning chemotherapy is similar for most products. Then Axicel, similar, Yescarta. Most of us have read and heard about it. Vexocel. Tisaj and Leclucel is the FDA approved product, and also the others, Axicel, Lisocel. And now for the myeloma, ID-Cell and Cilta-Cell, these are approved products. These are some of the package insert informations which you can very well go through. So I will run through it. What is my take home? So CAR T cells are finally here in India now, and we have synthesized our own CAR T cells. We all need to get sensitized on using these and understanding these better. Feasibility and safety has been proven. Learning curve will be there, but I don't think for the transplanter it will be a very difficult curve. It will be quick. And the CRS and ICANS, we need to understand better. We need to read, understand it better, collaborate with our critical care team. I will probably we'll have another talk on CRS and ICANS. It's a major topic of discussion. And we need to be aware of the indications, the patient selection, the toxicity, and the management of adverse effects. CAR T cell is likely to take off in India, similar to PTCI haplos, and it will happen. Not necessarily now, but maybe in next few months or years, I'm seeing it happening. Transplant will still remain a strong option for most of our patients. CAR T will probably be a bridge or a curative treatment for some patients who are not able to undergo or not candidates for transplant. Thank you. I'll be happy to take questions.
Thank you so much, Dr. Prashant, for a great talk. Yes, one question is there in chat box.
Thank you, Dr. Prashant.
Welcome, sir.
It was an excellent talk.
Thank you,
You
sir.
have told the details about the CAR T cells.
Dr. JM, sir.
Can you please?
Dr. Kungar, sir, one question is there. Can you, in chat box, can you see and can you ask that question?
I'm not able to see that question. Please.
No, but
just
that question actually not related to CAR T cell.
Okay.
It's not related to CAR T cell, but even after this talk, it can be answered. Now, the question is, when a patient is having a gallstones and which was removed and diagnosed with a leukemia, and the other one following that sentence is somehow it is not clear which type of a cancer can be occurred. So a kind of a thing which it's better directly they ask the oncologist, because this is not very clear question.
Yeah, I think it's the question is not clear in the context actually.
Right. But the person who asked, certainly you can keep in touch with with any of our oncologists, and the people can certainly answer that.
One question, Dr. Prashant Mehta. How much does this
Yes,
CAR
please.
T-cell
Yes,
therapy
please.
will cost in India?
Do you want a ballpark figure? It's not out yet, but I would say the cost should be anywhere between 25 and 35 lakhs or something. I'm not, I'm not the one selling it, but I'm just giving you a ballpark figure. This is my estimate, just a rough estimate. The Indian product CAR T cells, if you think.
In foreign countries, it's much higher than this, than the figure what you are
You're talking of 3 CR in US, 3 CR and 4 CR. That's the cost.
Yes. Thank you, Dr. Prashant Mehta. That was an excellent talk.
Thank you, sir.
Thank you so
Thank
much,
you, and
Dr.
thank you,
Prashant.
Sumant, for having me over in this very interesting meeting, and some novel discussions are happening. So very happy to attend.
Yeah, Prashant, one more request from you, that for the Indian Society of Oncology, we'd like to have a write-up on CAR T cells from you. I think I can ask this on behalf of Billy Magga sir also.
Yeah.
So
Good.
for all the oncologists, we have around 4,000 members. If you can give us a 2-pager about the CAR T cells, we'll be happy to publish it in this.
Sure. I will make an effort, and share a write-up with you. So much.
Thank you.
Surely. Thank you so much. Thank you.
Thank you, sir. Now let us move on to our next and last session. And this session is supported by Janssen Oncology. I would request Dr. Ramesh Pilimaga, sir, to invite our next speaker.
Yeah. Our next speaker is Dr. Ayaz Ahmad, a senior consultant in the Department of Hematology from Rajiv Gandhi Cancer Center in Delhi. And the topic is quite interesting. It's a multiple myeloma, which has been one of the successful story of oncologists. But what are the newer drugs or newer agents that's being used? And that is the one which is going to discuss. Over to Riaz.
Hi. Good evening, sir. Thank you for giving me opportunity. Thanks, Sumant. Sorry for being late for some technical glitches. So I like to share my screen. I hope everyone is able to see my.
Yes, sir, it is visible.
Yeah, it's there.
Yes, sir. Yes.
Yeah, sure. So first of all, thank you everyone. Sorry for being for this technical glitches. I have recently moved to Max Arcade Super Specialty Hospital. I left Rajiv Gandhi 2 weeks back. So this was the new, I was introduced as from Rajiv Gandhi. I'm now from Max. So this we all, everyone knows that the diagnosis of multiple myeloma, international myeloma, International Myeloma Working Group criteria for the diagnosis of multiple myeloma. This is the MGUS, smoldering myeloma, or active, or you can say the symptomatic multiple myeloma. So MGUS, I'll not go into detail. Let's. This is for the students who have joined this meet. And this is the current role of imaging in multiple myeloma from initial days of doing skeletal survey, that X-ray used to be there, to the low dose whole body CT to whole body MRI. These are the different parameters which we can be to the PET scan. So advantages, disadvantages. Everybody is working in a different setup. So not only the we can say the skeletal X-ray is okay, and it is the or PET scan the other side when you have the facility that can be seen both in the combination as per the recommended to for is there for the PET scan also. Now, in the revised ISS staging, what we used to have the albumin and beta-2 microglobulin. Now, the recent entry to it is the LDH and the fish analysis of our the chromosomal markers, which you can have according to the we can redefine into the revised ISS staging. And basically, you can have the cytogenetic abnormality of 414, 1416, 1420 or del17 and the high risk GP there. The laboratory features of ISS3 or increased LDH. LDH is a specific marker which we sometimes have difficulty in initially doing, especially the plasma cell leukemia part or the extramedullary involvement part. Age is in India we see the myeloma at much younger age what the Western world see, and this is the functional high risk is determined after the initiation of therapy, that is either primary refractory or rapid progression within 18 months of diagnosis. These are few features of high risk myeloma. So what I have one slide for the case series that the total number of patients we have 12. It was 8 was standard risk and 4 were high risk. Induction regimen we used was VRD, and after 2 to 4 cycles average response was no response to stable response. Next induction regimen we planned for DARA, carfil, pomalidomide, dexa. So daratumab, carfilzomib, pomalidomide now commonly being used, but those who had no response or stable disease, we use this. And post 2 cycles, the average response or PR to VGPR. 7 patients were taken for transplant with melphalan 200. Day 60 response, those who had PR went to the VGPR, those who were in VGPR went to CR. And after that, we gave 2 cycles of consolidation with DARA KPD, followed by maintenance with either DARA carfil or carfil alone, depending on the patient's availability. So the whole point here is the patient who had no response to initial, these were the initial defined for us the high risk, those who are not responding. We see commonly these patients, those who have not responded or who have stable disease after even 2 to 4 cycles of initial VRD triplet regimen. These patients still can be given a chance to increase their PFS if we have the early initiation of daratumab, carfilzomib, or pomalidomide, rather than waiting for a longer time and seeing that these patients, whether they relapse or they have some other progressive disease. Now, the current consideration for initial treatment and for myeloma for younger and fit patients, we know we have come from doublet to triplet. Now, it's triplet or quadruplet, followed by autologous transplant. Maintenance of therapy post-transplant, we are giving initially to maybe 1.5 decade back, we were contemplating whether maintenance has a role or not. Then came the thalidomide, whether or we can give it to 6 months to 1 year. Then we were going into the 2 years or extended maintenance. So finally, the maintenance has come a long way, that it has to be given post-induction therapy, post-consolidation by other autologous, are continued given 6 to 9 cycles of therapy followed by maintenance and continue till it relapses. So the overall goal of this initial therapy is to maximize the depth and duration of first response. The longer the duration of the first response, the higher chances that patient will have longer PFS. Now, the role of MRD is now coming in multiple myeloma. A lot of centers have been started practicing. All the talks will be based on the MRD, how to get especially the Griffin and the Cassiopeia trial, which was being published 2 years back. Then they had this Griffin and this MRD talk, and the therapy which they planned was the giving VRD, taking the quadruplet therapy, going for the MRD negativity and follow-up of the patient with MRD negativity so that they can have the longer PFS. And first time they were there, upfront daratumab usage has showed that okay, it affected had the overall survival benefit also. Now, 3 drug, 4 drug, we have always been the talking about whether VRD or Cybody. This has been the we know that these are the standard of care, and whether to add the fourth drug, that is the quadruplet, whether Daratupan is the question. So in our practice, what we do is the adding Daratumab in the high risk patient. Standard risk, I still believe in the some select of patients we still can add the Daratumab, and that can give actually the operation cure, especially the patient in elderlies who have been treated with quadruplet, and if there are not much toxicities, and they can go into remission, and if they achieve MRD negativity, they may go into the permanent cure. That some select of patient can go into permanent cure with this quadruplet therapy. So all this needs to be followed up with other trials coming into play. This needs to be seen whether this operational cure in myeloma with MRD, while the monitoring of MRD is seen with quadruplet therapy or not. Now, the clinical trials with quad therapy in newly diagnosed myeloma. So this was the Cassiopeia trial, which I was talking, Daratumab VTD, 4 cycles, followed by transplant, followed by again consolidation with Dara VTD into 2 cycles, followed by Dara maintenance or observation. So in this, what they said with the patient who received the Dara, the stringent CR was better in the Dara VRD group, and we did Dara-based therapy as compared to those patient who has not received the Daratumab. The Griffin update MRD negativity, by the time they have ended, the most of the patient, you can see the MRD negativity was up to end of induction. It was only 8%, which by the end of study, almost 30% had this 10 to power 5 or 10 to power minus 6 level of MRD negativity. So that's quite impressive. So in the Griffin update, the intention to treat analysis population, the median follow-up of 50 months almost, and the median PFS has not reached in here. The longest PFS in Dara group rather than Dara versus the the group which has not received the Darzalex. The progression-free survival curve separated beyond 1 year of maintenance. So we can see this has actually changed our practice. So upfront initiation of monoclonal antibody does make a change, and in the continuation, the only catch point in our practice is the finances. If a patient, those who can afford, I think so, in I'll watch for giving Darzalex upfront. So whether these adding had changed Darzalex adding any in the infection, the Griffin trial has showed that incidence infection is the highest in earlier cycles, and in maintenance, upper respiratory infection was the most common infections in the during COVID era. In Dara RVD, the total 5 had, and the RVD 2 patients had similar rate of infection, leading to, so it not much difference. The both had the similar rate of infection, not much difference of adding the. So this is the another monoclonal antibody, isatuximab with RVD, and in the induction phase, the same way it was planned, isatuximab RVD, and followed by transplant, followed by ISA-R maintenance. And again, we have almost got the similar results. It was not any difference, and it was again. Now, whether again we do this was one point of adding Darzalex, which we should initiate in our practice in some select patient according to the physician discretion. This is my take home point. The other is the transplant still the standard of care? Ever since the botulism inception, the IMiDs have came, the proteasome inhibitors have came, we have been contemplating whether these drugs will take away the transplant. But what transplant still remains the gold standard of care? It's still the transplant has not. So in India, actually, it is the cheapest. Actually, now I can say the transplant is the cheapest way a patient can be gone into the longer progression, can achieve a longer duration of progression-free survival, rather than with you can say any monoclonal antibody. So we have seen this in the trial that whether you use the RVD based regimen or lenalidomide maintenance or KRD, the whatever therapy you have given, that they have not been able to replace the transplant as a standard of from the consolidation. So this is the phase 3 IFM 2009, in which the VRD plus ASAT in the newly diagnosed myeloma. And if we can see The trial design was VRD 8 cycle or in one arm, and the VRD 3 cycles followed by transplant, followed by VRD 2 regimens, followed by maintenance. Before and after maintenance, they would check the MRD status, and you can see the patient who had received the upfront transplant, they did better. The median PFS was 50 months in the transplant arm rather than the non-transplant, which was the VRD, which has 36 months. So, but there was no difference in overall survival. Now, this is the another study in which the role of upfront transplant was considered RVD versus ACT. So we see that transplant have this role if we do, and in India, it's still considered as the better option to do a transplant rather than doing not to do a transplant. Those who are eligible and should be promoted as much as possible. Going by the cytogenetics risk, also the person who had in the high risk cytogenetics, the patient who has gone the transplant way did better even in the high risk category. The quality of life, it doesn't matter. The transplant didn't affected the quality of life, and it was when. So this was my third point. First was adding of daratumab. Second was including of maintenance, and third the transplant still. And what we see in our regular practice, not more than 10 to 20% of a patient, 20 is also, I'm quoting little by, go for transplant. If we can promote then doing this, it is going to help a patient in a bigger way. Now, only VRD is the standard regimen, or we can move ahead with carfilzomib RD followed by transplant, or KCD followed by transplant, or KRD12. So this in the Forte trial, they designed a trial and which is better than the other. And in this again, the carfilzomib, lenalidomide, dexamethasone followed by with transplant did better than the rest of the two. So even of the 4 years, the progression-free survival was 69% for the KRD with transplant arm. So I'll just skip. Now, moving for the maintenance therapy, moving beyond single agent lenalidomide, whether the alternative single agent therapies with ixazomib or daratumab will help. Yes, or adding dual maintenance with bot-len, or you can say bortezomib, ixazomib, or carfilzomib, whether these are going to help. Yes, whether when in the high-risk myeloma, when you add the dual maintenance, it is better than the single agent of lenalidomide. So this was the PFS and OS of the lenalidomide maintenance after the ASAT multiple. This is the meta-analysis of 3 phase 3 trials in which, if you see when the lenalidomide was added as a maintenance therapy versus observation, we all know this both it affected the PFS and the OS in the long run. So this is again going by the cytogenetic risk, whether the standard risk or a high risk or ultra high risk, lenalidomide arm did better. And now, in coming to the tourmaline trial with maintenance, ixazomib and placebo, you can see that going by the MRD stated progression-free survival was better with the ixazomib arm and MRD. So all different trials, those who have gone with the MRD or going by the lenalidomide or these by they showed. So these practices should be incorporated as much as possible. Now, this is the another whether the maintenance of I was talking whether it's a LEN maintenance or DARA maintenance. Again, DARA maintenance, those who have received in their as a maintenance part, they did better. So this was another. Then the Cassiopeia part 2, the PFS of the patient who received daratumab maintenance. We can see the patient who have received daratumab did better than the observation only. Now, the PFS from the second randomization in the same by induction consolidation maintenance therapy, you can see those who have any patient who has received Darzalex, whether it is VTD or VTD followed by D or DVTD followed by observation, anyone who has received Darzalex in the initial part or later, they have done better in the long run. So going by the, I will just skip this. Now, coming to the next point is what about the MRD? Achieving MRD negativity, particularly sustained, is associated with improved long-term outcome. MRD negativity is not currently used to guide treatment, but multiple ongoing clinical trials are exploring MRD-guided treatment decisions, MRD being evaluated as a potential surrogate endpoint. So if you are able to achieve MRD negative even by flow, we can say the patient is going to do better in long run. The only thing is the patient has to be done undergo bone marrow again and again for doing this MRD study. So the summary of the currently available treatment options for the newly diagnosed transplant eligible myeloma. We say that the recent randomized studies showing PFS benefit for the upfront transplant, induction regimens, RVD or KRD has been the standard of care, especially in the high risk KRD has been used. Improved depth of response with addition of anti-CD38 monoclonal antibody has shown the better results in the ongoing phase 3 study. And the maintenance, the lenalidomide, whether continued until progression, has been the standard of care. And with adding of monoclonal antibodies into the maintenance, and especially the high risk, they did show the better PFS than who has not received the treatment. The treatment consideration for the ascitic fit the transplant. Now, this we can say that the 3-drug regimen is available. The frail, unfit patient consider using doublet, and in renal dysfunction, lenalidomide dose-adjusted based creatinine clearance. Cardiac, those patients with having cardiac dysfunction, avoid carfilzomib. Those with neuropathy, administered bortezomib subcutaneous, which we have been using it, and consider ixazomib-based therapy, IID-based therapy. So this age is an important issue. For them, it's the elderly. For us, it's the younger age. Comorbidities are there with almost all the patients we see, either in form of hypertension, ISG, diabetes, renal insufficiency, osteoporosis, psychological issue, frailty, altered drug metabolism, limited social support, limited. All these factors affect our treatment protocol. So whether it is just going for the last part of our. So to end my talk here, I'll say the summary of the newly diagnosed transplant ineligible myeloma study. Important to adopt therapy to functional status and disease risk. Start at a lower dose with doublet therapy in patient with poor functional status and escalate as tolerated. Ideal duration is unclear for the standard risk therapy. What we see is the Lendex uses for 18 months still remains the standard of care, and the treat until disease progression for high risk disease. With this, I would like to end my talk. Thanks, organizers, for giving me the.
Yeah, thank you, Dr. Riaz. In fact, you have covered it very well, starting from induction therapy to maintenance therapy, and what is really available for us when the transplant is not possible, and what are the drugs to be used. And you have given a very clear picture to the people and who can really use that. With that, if there's any other questions, chat box, I'm seeing questions. Let's see, Riaz, can you see that? There's one here. May I know the role of MRD in NDMM?
Newly diagnosed.
Yes.
Sure. So, sir, the role of MRD in newly diagnosed multiple myeloma, yes. If the newly diagnosed multiple myeloma, both Griffin and Cassiopeia trial showed that if upfront you can use quadruplet, the Darzalex-based therapy with VRD, that is Dara VRD, and you are able to achieve the MRD negativity, those set of patients, they had not only the progression-free survival was better, even it impacted the overall survival. Whatever studies we had initially, it impacted only the PFS, not the OS. But the first time, addition of monoclonal antibody upfront made the impact in the overall survival. So this was the importance of MRD negativity. So other point what we need to understand is something called operational cure in myeloma. If a patient, just giving an example, any myeloma of 65 to 70 years of age, and we have used this quadruplet and he's able to making the dose adjustment for his tolerance, and if we are able to achieve the MRD negativity for him, what we say the myeloma non-curable disease, maybe the operational, if he is able to achieve MRD negativity, can be the operational cure for him. So in fact, we are doing better if we use it in those set of patients, and will be able to get him for a longer duration of his PFS and OS benefit. He will get more PFS and OS benefit.
Good, that's good. A continuation of one more question from the same gentleman, and it says, are you going to do a cytogenetic, in multiple myeloma? Is it for all patients or only high-risk patients?
No, we will do the cytogenetics for all patients. At diagnosis, everyone should go the cytogenetic profile. I think so. Fish analysis is being available. It's cheaper. It's not that it's not going available. It's available for almost every patient, and it should be done. It should be mandatory so that you can prognosticate the patient at the very beginning.
Okay, good. That's all patients. Yeah, fine. I think thank you, and thank you, Riaz, and go to Gupta.
Thank you, sir.
Yeah.
Thank you, sir. I think we had a very fruitful session to end the year and a very nice day. I'm especially thankful for Indian Society of Oncology to have these new series of webinars, which will be good for the science. I thank all the panelists, all the speakers, moderators, and chairpersons who gave their day before the holidays, and above all to the sponsors and Mice Ideas and Miss Sharma for hosting the whole function. I'm thankful to everyone.
Thank you, sir.
Thank you.
A special thanks to Bilimaga, sir.
Thank you so much.
Sir, we had around 300 logins today, sir.
Oh, I mean, that's very good. That shows
Yes,
the
sir.
interest, among our members. That's excellent.
Sir.
Thank you, Suman. Thank you,
Thank you,
everybody, and including the faculty and who took all the interest to teach us, and also collect the handouts or the write-ups, and you can publish in our the newsletter and even in the journal.
Sir.
Thank you so much.
So
Good
we'll
night.
be collecting for the newsletter and we'll be sending a request to all the joinees about the IEs. So
yes, that will be
thank
good.
you, sir. Thank you, sir.
Yeah, Happy New Year. And
Happy New Year, sir. Thank you, everyone.
Thank you. Good night,
Thank
sir.
you, ma'am, for this lovely webinar.
Thank you. Okay, sir. Bye.